Excellent. We're there. Can we invite you then, please, just to describe what what happened to you?
It's kind of, well, where do you want me to begin? Because it goes back quite a long way, and some of the issues are not necessarily related to my Christian beliefs. Some of them are, or possibly are, and others are related to other, work that I do on behalf of pro-life uh, groups and pro-life activities. I suppose I was a member. I am a member of the Catholic Medical Association. I was elected their president in 2018, which gives additional responsibilities and roles compared to the other council members and other members of the CMA. Um, I suppose the whole issue began when we became involved with providing abortion pill reversal services, because that's really what led to all of the issues that developed subsequently. We were approached actually initially in 2014 by one of the pro-life organisations, Life, to ask, could we help women? Because women were coming to a number of the pro-life organisations within the UK, having taken the first abortion pill, Mifepristone, and they had heard, or they had come across the notion that it might be possible to still preserve the pregnancy and save the life of the baby if a certain type of treatment called abortion pill reversal treatment was offered to them, as long as they hadn't taken the second pill. Now, we knew nothing about this, and back in 2014, the service had become widespread and available within the US from 2012 onwards, but we hadn't heard any details from it at that time. There was very little information online or available to the public about the service at that stage. But we decided we'd look into it. We were skeptical. We had concerns, safety concerns for both the mother and for the child if the child did happen to survive. But we looked into it, and not a lot of information, as I said, was available. But by 2018, before we had done anything concrete on the issue apart from looking for information, by 2018, we were approached by another pro-life organisation at our annual conference, Claire McCulloch from Good Counsel Network, and she basically pleaded with us because more and more girls were coming to them. They had tried to help them by trying to find private obstetricians in the London area that might offer them help, but they weren't able to guarantee that the help would be provided. So I promised Claire that I would find out more, and I went to the US to meet the pioneers of the abortion pill reversal, which is using basically simple progesterone, which has been used for decades to try and prevent miscarriage in women who have low levels of progesterone or dysfunction of progesterone in the early stages of pregnancy. And this is really what abortion pill reversal is. So we became involved, and I reported back to our council that year. And in November 2018, we made a decision that we would write to various authorities within the UK, so the Royal College of Obstetricians, Royal College of GPs, NHS England, to tell them about this treatment and hoping that it would become mainstream medicine as a service that women were requesting. And then we got disappointing responses from them, and none of them were prepared to support it. The RCOG in particular was, their response was a little bit mystifying, and they said that their main reason was that they do not promote treatments that are not officially recognised or that are not indicated for that purpose. And we pointed out to them that like off-license, they're not promote off-license medications. But we pointed out to them that at that time, Mifepristone, the second drug used in abortion, was an off-license use. It's a drug that's used for management of peptic ulcer disease, but is not indicated or licensed for abortion. But yet they were very happy to promote its use in that situation. And similarly, methotrexate, which is an anti-inflammatory drug used in a number of chronic inflammatory conditions such as rheumatoid arthritis, quite a dangerous drug if in the wrong hands. But they were promoting its use, its off-license use for the medical management of ectopic pregnancy. So we pointed out this to them in our response, hoping that they might see the light and come on board with providing the service. That now that we had addressed the concern that they had, but we got no response from them. Similarly, we wrote to NHS England and the Royal College of GPs and got no second response from them. So we sent them a third letter to say that we were disappointed that they hadn't responded to our other letter, but that we were now going to go ahead and promote this this treatment, this service to the general public, and we presumed they would have no objections to it. In the meantime, before we'd done that third letter, actually, we wrote to the GMC asking for clarification. And we had one basic, simple question. If a woman comes to a doctor having taken the first abortion pill, and she has now withdrawn her consent and wants to withdraw from the abortion process, hasn't taken the second pill, how should a doctor respond? And the response was reasonable. They said that it's not within their remit to provide clinical information, but they pointed us to their good practice, medical practice, that any patient always has the right to know all the options available to them at any stage in their treatment, and that they are entitled to withdraw their consent for treatment at any stage. So while they didn't directly address the specific question, they gave us enough to make us feel that we were secure in going ahead with at least providing mothers with this alternative option that was, progesterone is licensed. It was an off-license use of a licensed drug that had been around. And actually, this is the perfect situation, because while progesterone generally is not very helpful in preventing miscarriage, it is the only drug that's recommended for this purpose, in the hope that the cause of the miscarriage might be low levels of progesterone, in which case it is the ideal treatment. So this is the equivalent. So basically, the abortion pill, Mifepristone, is inducing a state of, well, not necessarily low levels, it's mimicking that state. It's preventing the actual function of the progesterone. So by giving extra progesterone, it can, not always, and we always point this out to the mothers who come to us, but it has a much higher success rate than doing nothing, which is what the Royal College advocated, that you don't do anything, you just don't take the second pill and you wait and see what happens, what they call expectant management or conservative management. The success rate with saving the baby in that situation is less than 20%. The success rate with progesterone is more than 50%. So we're more than doubling the survival rate with this very simple, widely available, inexpensive treatment. So we started providing this service. And we're getting more and more calls. Myself and one other doctor within the UK, who was also a member of the Catholic Medical Association, were providing the service, not realising that there was any concerns over it. Women who came to us were very happy, even those where the treatment didn't work, and it was almost 50% where it didn't work. They were still very grateful that somebody was trying to help. We never put it across that we were Catholics or Christians. We were doctors coming to the service of a woman who presented with a specific problem. We had a treatment that could be offered to them, and in many cases, more often than not, it worked, and in some cases it didn't work. Even some of the women, about a third of the women who discussed the issues with us, decided not to go ahead with the treatment once they, for various reasons, usually because of coercion from partners or boyfriends or family members. They thanked us for providing and taking the time, but they didn't go ahead with the treatment. And we didn't try to chase after them or force them to take the treatment. We pointed out it was an option to them if they wanted to avail of it. Then on the end of April, 28th of April 2021, myself and Dr. Eileen Riley, who was the other doctor providing the service, we both received simultaneously emails from the GMC, the General Medical Council, stating that serious allegations of potential professional misconduct had been brought against us. In my case, it was the medical director of Mary Stopes International, or MSI Reproductive Choices, as they prefer to be known, and also the president of the Royal College of Obstetricians Gynecologists. Both had raised complaints against me. In Dr. Riley's case, it was just from the Royal College of Obstetricians. MSI didn't appear to be involved, at least not directly in her case. But the allegations were very similar, that we were enforcing our pro-life beliefs and our Catholic beliefs on these vulnerable women, that we were using an unauthorized medication. We weren't following the guidelines on abortion provision. In my case, I was also charged with bribing women to participate or to take part in this treatment. But the main concern that for the purpose of this group, this committee, is the concern that was raised about trying to enforce our Christian beliefs, our Catholic beliefs, and specifically, and I think you probably have a copy of the letter, specifically the Royal College of Obstetricians, in their letter. It was written by the legal advisor to the president of the Royal College of Obstetricians. He specifically raised the point that they weren't so much concerned about the treatment, but they were concerned about the people involved. and they described myself and Dr. Riley. And in my case, they said one of them is the president of the Catholic Medical Association. And they implied that because of this position that I would not be a suitable person to provide non-judgmental, accurate, truthful information to women presenting with this crisis situation, and that I could be guilty of misconduct as a result of that. So that then led to the investigation. The initial step was an MPTS, Medical Practitioners Tribunal Service meeting on the 12th of May, which both of us were. I was defended by the Christian Legal Centre at that, because when they heard about my case, they were determined to become involved. Dr. Riley was defended by a secular medical defence group who gave her different advice. That their approach to it was that, okay, these are serious allegations. Let's not make it worse. We know you're guilty of what you did, but let's try and aim for damage limitation, basically, and not challenge this and see what happens. Whereas the Christian Concern approach, or the Christian Legal Centre approach, was we're going to fight this. This is unjust. We're going to fight this, and we're going to do everything we can to fight these allegations. And if the decision goes the wrong way, we will continue to fight and appeal the decisions, which they did. So we were both found, I suppose, guilty, or at least deemed that the allegations were serious enough that we should be suspended. The GMC wanted to suspend us completely from the practice of medicine for an 18-month period, which would be the maximum penalty that could be imposed, maximum conditions that could be imposed at that time. The tribunal thought that was a little bit disproportionate and harsh, so they opted that we could still practice in our other roles as physicians. So I'm a cardiologist and then a general medical physician, and Dr. Riley's an obstetrician, so we could still perform our general roles, but we weren't allowed in any way to provide this abortion pill reversal service. So in my case, it was that I must not administer, prescribe, or recommend progesterone in abortion pill reversal. And I was also told that I must not do any private medicine or any charitable work with any charitable medical groups without written permission from the GMC beforehand. So these were imposed. Well, the intention was to keep them in position for 18 months, but to be reviewed every 6 months, because that's apparently legally what they're required to do. So Christian Concern took this in hand. We got expert witness, a fellow of the Royal College of Obstetricians, to look at the allegations, and he agreed with our side of the story that they were not in any way representative of professional misconduct. We got statements from a number of the women that we had supported, including some of those who had decided not to go ahead with the treatment. So we got a wide range of supportive treatments. We could have got about 40 or 50 at that stage, but we decided that 10 different stories might be sufficient. We presented them to the tribunal of just the papers in preparation for the next review that was due to take place. We were told then, so instead of having to wait 6 months, that they brought the review forward to 3 months because new information had come to light, new evidence had come to light, because there had been no evidence looked at in the allegations. It was all that was looked at in the first tribunal hearing. And so this was the first time that evidence was actually brought, and it was from our side. Well, we presumed it was from our side. And at the tribunal, which was brought ahead 3 months, so I think in August of that year rather than October, November, we were a little bit dismayed at the very start of the hearing. The president of the tribunal said that, well, we're not going to actually look at any of the evidence. We're just going to see if the allegations are still significant enough to, and it was a Zoom call because this was during the COVID time when public hearings or in face-to-face hearings were not allowed, or at least carried out on a regular basis. My representative from the Christian Legal Centre just threw up his hands in dismay, because basically the evidence we had provided and the reason that the tribunal was called seemed to be on the basis of the evidence. They decided they weren't even going to look at the evidence. So they just looked to see were the conditions imposed still applicable, and they determined that they were, so they were to stay in place for another 6 months until another hearing could be heard. So at that stage, my legal team decided we were going to take things a little bit further. So they made an application in September to the High Court, stating that the conditions that had been imposed upon me had been unjust and unnecessary and disproportionate. And we expected that we wouldn't hear from the High Court for some time, because at that stage there was quite a backlog from the COVID of legal cases. So we were surprised to hear that by September they offered they said that we would have a hearing by February in 2022, which surprised us, but pleased us at the same time. As we were busy then getting our case together for that High Court hearing. In the meantime, I mentioned that we had an expert witness report from a fellow of the Royal College of Obstetricians. We received a number of email correspondence from the GMC to say that they were struggling to find an expert witness on their side. Eventually, they found one just after Christmas, at the end of December, early January. They found an expert witness to look at the allegations from their side. And surprisingly, when his report came out at the end of January, it was very supportive, almost identical to the report from our expert witness. So a High Court hearing was scheduled to take place at the end of February, and 6 days before the hearing was due, I received initially a phone call from my legal team to tell me the good news that the case against me had been dropped by the GMC. And then about half an hour later, I received an official email from the GMC informing me of their final case investigators report, that they decided that there was no case to be answered, that there was the phrase they used was there was no possibility of finding any evidence to support the allegations that had been used. And they didn't apologize and just stated that the fact that the case had now been dropped. Although it still had to go to the MPTS. It was the MPTS who had imposed the conditions, so they had to apply to the MPTS to say that they no longer felt there was a case to be answered. And then about a week or so later, just early March 2022, the MPTS formally declared that the conditions no longer applied. Interestingly, Dr. Riley, who had received legal support from a different group, the case against her wasn't dropped for about another 2 months later, because there was no rush in her case, because she hadn't threatened to take the GMC or the MPTS to any court. So they took their time, even though the allegations were more or less the same, and the conditions opposed were very similar to mine, but they eventually dropped the case against her. So that allowed us to resume the service that we had been providing to mothers up to that point, and we've been doing that ever since. I don't know if anyone wants to interject at any point. That's the first part of the story then, before we come on to some of the other more specific issues, which I think was the reason why Mr. Adamus contacted me in the first place, because of subsequent protests and objections to my presence raised.
Maybe we can actually then ask a few questions about this, and then we'll go on to the second part, because my goodness, you've given us a wealth of material here. So, yeah. Just a very general question to start off. Chemical abortions, I believe over 80% of abortions now are due to these pills. Is that right?
Yeah, more. If you take the whole United Kingdom, it's coming close to 90%. So it's over 80%. So it's about between 85 and 89%. It varies year by year, but it's over 85%. And in Scotland, it's almost 100%, 98 to 99% in Scotland. I haven't seen the current figures, but last year's for Scotland, I think, was 98%. In England and Wales, about 85 to 88%.
Gosh. I mean, that's absolutely massive figure, isn't it?
And many of those, as you know, are done without any face-to-face consultation with a doctor. Done mostly, the majority are done. We don't know exactly how many, but the majority are done by telephone conversation, and the drugs being sent out by post to the mother. Then has the choice to either take them or not take them, to keep them in a drawer until the time arises when she might decide to take them. And of course, that raises the other issue then of taking them later than they're legally allowed to take them. They can legally take them, I think, up to 24 weeks. The Royal College recommends that any abortions after 14 weeks should really be done under clinical supervision and in many cases, a surgical procedure may be necessary. because of the risks increase to the mother, and also the possibility of the pregnancy continuing after that stage. But a majority of them take place without any medical supervision or without any medical follow-up in many cases.
And how often do women actually regret? Do we have any stats for that as well?
No, we don't, unfortunately. We know that a lot of women do regret them, but we don't know how many. We only know the ones that come to us. But then we meet women many times. I've met dozens of women, so certainly over 30, 40, 50, who've heard me speaking at various events or have contacted me and through social media to say thank you for the work you're doing. I deeply regret I didn't know about this service before I did what I did. So we know that there are women, but the exact numbers we've no idea.
Mm. Um, I am not in any way medical, so I don't sort of fully understand all the drug use here. But something that leaps out to me as a layperson is that you mentioned that progesterone is very commonly used to help if a woman has a threatened miscarriage. Now, my understanding is that the drug being offered for abortion pill reversal is just progesterone.
Yeah,
So,
correct.
I mean, help me out here. Why are there so many allegations being made that this is a dangerous treatment that is being prescribed when it's something that seems to a layperson to be routinely used if someone has a threatened miscarriage?
Yeah. Well, that's the key question. Um, the only clue we have to that, or the clues we have to that, is that initially, because I mentioned that the service had been offered in the US from 2012, it was actually discovered accidentally on two different occasions on both sides of the continent, one on the west coast, one on the east coast. The very first one, I think, was 2006, when a woman had taken the first abortion pill, regretted it, and then contacted her doctor to know was there anything she could do to try and save her baby. He didn't know, but he had a friend of his who he knew was an obstetrician involved with fertility awareness and fertility management. So he contacted him, and knowing what he knew about mifepristone, knowing what he knew about progesterone, he thought, well, there's a chance that maybe if we give progesterone, as long as it's not too late, as long as she hasn't already miscarried, there hasn't been major bleeding, severe pains, and that's still the criteria we use for starting the treatment. If the woman already has had heavy bleeding or severe pains, it's too late at that stage. So he decided, well, give her progesterone and just see what happens. It won't do any harm. We use this routinely when a woman has a threatened miscarriage. And lo and behold, it worked, and the child survived. And that was just an anecdotal case that you could say, well, the child might have survived anyway. It was coincidental. And about a year later, on the other side of the continent in California, a doctor received a call from a colleague of his in a neighboring state, actually, because he knew about him because of his fertility work and progesterone work, to say a woman had come to him with exactly the same story, and could he recommend anything, and he recommended progesterone, and again that child survived. They got to hear each other's story about a year or so later, and then 2012 they formally established the abortion reversal. They did a couple of sort of minor studies to small numbers of women, and they found the success rate was higher than would be suspected by just conservative management alone. So they realized that this was safe, and it was. We didn't know about this at this stage. It took several more years before the information became widely available on an international basis. But by 2018, there was a good deal of information. In fact, George Delgado published his first major paper on his landmark study on that in 2018, which was an observational study. In the meantime, the opposition developed within the US from the abortion providers. The main protagonist, or the main person who was opposed to it, is a guy called Daniel Grossman, who's based in California, a prolific abortionist, very much involved with promoting abortion drugs as opposed to surgical abortion, but although he does both. And he was asked in a telling interview based on Huffington Post, which it's not recognized. Huffington Post is not recognized as a pro-life sort of form of media. But he was asked, what are your concerns, Dr. Grossman, about this? Is it the treatment? He said, no. It's not the treatment. It's the rhetoric. the rhetoric that women change their mind. Well, we know women don't change their mind, which obviously has proved to be not the case, because at this stage, 7,000 babies have been saved, mostly in the US, but we've 75 that I know of in this country, with another few on the way. But thousands of babies have been saved. And if you take into account that not all of those treatments would have been, or not all of the treatments offered would have been successful, so there's at least another 5,000-6,000. So within the last 12, 13 years, thousands, tens of thousands of women probably have changed their mind and sought this treatment. So women do change their mind, and probably many more than we ever get to hear about. So that was the first thing. So that was the argument that was used, that women don't change their mind, and that was the only argument that was against abortion pill reversal for several years, until another obstetrician or abortionist from California, Mitchell Kreinen, he added in an extra objection that it doesn't work. It's junk science. There's no basis to this, which is not true, because there are animal studies, and several of them at this stage. The initial animal study was a Japanese study that looked at this issue. They weren't looking to try and save babies. They were studying the properties of the abortion drug and progesterone and so on's effect. And they found that by giving simultaneously in a rat model, Mifepristone and progesterone to pregnant female rats, that there was a 100% success rate in saving the pups of the offspring. Now that doesn't happen in real life, but it just showed, that was the first study to show that it was possible for progesterone to interfere with the function or the work of the way that the biological work, physiological work of Mifepristone. So that was the first study to actually show that in an animal model. Subsequently, in more recent years, a group in Ohio have shown that given the equivalent of waiting 24 hours, so given the Mifepristone, then in rat terms, because pregnancies happen much quicker in animals than in humans in general, given the equivalent of waiting a 24-hour period, which would be a matter of hours, I think, in the rat model, they found there's an 80% success rate in saving the babies, whereas if you don't give there was a 100% mortality rate in that particular rat model, in both cases, actually, in the Japanese one and in the Ohio one. So there are certainly animal studies to show that progesterone can prevent and reverse the effect of mifepristone if given quickly enough. Then we've the observational studies, so that we have observed, not only in my own work, I've helped, 155 women have come to me. Not all of them have started the treatment, but for those who have and those who've continued the treatment and those who haven't been lost to follow up, the success rate is 55%. But when I talk about this treatment, the way I try to get it across is, if you take any medical condition with a 100%, like a guaranteed mortality rate of 80%, which is what it is if you do nothing. So a guaranteed 80% mortality rate for any medical condition, and you can introduce an intervention, whether it be electrical treatment or drug treatment or some other treatment, and if you can reduce that to less than 50% mortality, certain mortality from 80% to less than 50%. But we're talking about Nobel Prize interventions here. This is worthy of consideration for Nobel Prize, even though the numbers affected are smaller compared to heart disease or stroke disease or other medical conditions. But there are very few, if any, medical interventions in history that have such a profound impact in preventing certain mortality. Even the closest I can think of in my own field is defibrillation. So if someone has a cardiac arrest and they have a particular rhythm, and if you shock them quickly enough, there's a good chance that you'll save them. Now, in the out of hospital community, the survival rate for cardiac arrest is, depending on where and who and the facilities that are available, is 10, 15, 20% at the very most. And even those that do survive initially, a lot of them, because of the underlying condition that the patient has suffered, are not necessarily going to survive for very long afterwards. But you can get them to hospital, and you can survive, help up to 20%, 15 to 20% of people survive in an out of hospital cardiac arrest situation. And within hospitals, it's similar, higher, because attention is usually quicker. So if someone goes into ventricular fibrillation, and certainly if they're on a heart monitor, there's a very high success rate, at least initially, for saving their life. But again, many of those patients will not survive to to actually leave hospital because of whatever the underlying condition was, severe heart failure or some other almost terminal condition. So there are very few interventions in medicine that has had such a high success rate of preventing certain mortality. And that's the way I try to promote it when I'm talking to groups or individuals about it. And that's the truth. That's been my own experience. That's been the experience worldwide of the numbers of publications. And they're mainly confined to the US and Australia, which have produced a number of papers on this issue. All observation. That's one of the current objections. And it's a reasonable objection that we don't have a randomized controlled trial, which is the standard for investigating a new treatment in medicine, a randomized controlled trial. But to do so at this stage, a randomized controlled trial would not be ethical, because given the information that we already have about this treatment, if a woman comes looking for this treatment, it would be very cruel to say to her, well, we're going to put you into a trial where we might give you the real drug, or you might get a placebo drug or a dummy drug that but when she desperately wants to save her baby, and very, very few women would consent to taking part in such a trial. Having said that, I would have liked if there had been a randomized controlled trial performed in 2012 or 2010 or 2009. That might have been helpful, because we didn't have the same wealth of information at that stage. To put a very close analogy, or almost identical analogy, when a patient comes to hospital with a paracetamol overdose, whether it's a very serious one or even a moderately severe one, worldwide they all get the same treatment. We give a drug called N-acetylcysteine, which helps to prevent the poisonous effect of the paracetamol affecting the liver and the nervous system in particular. And when I look back as to how did we come to use this treatment, and there isn't any randomized controlled trial. There was an observational study performed in 1971. Because it had been observed that N-acetylcysteine seemed to be a logical antidote to paracetamol. Other treatments had been tried and without success. And then it was observed in this landmark study in 1971 that by giving N-acetylcysteine, you greatly improve the survival rate of and reduce the risk of serious complications for patients who had taken paracetamol. And the authors in the paper actually addressed the issue of not having a randomized controlled trial, and they said to do so at this stage, given the information we have, would be unethical, which is almost identical to the situation we have with progesterone. So progesterone, it's a natural antidote for mifepristone.
Okay. Have there been any adverse reactions recorded as a result of giving abortion reversal treatment to the mother or to the fetus?
No, is the quick answer, but to elaborate a little bit further, because that was our concern when initially we were approaching 2014, when myself and the other council members of the Catholic Medical Association, we were skeptical. We thought, again, that same thing, is there really a need for this? How often does it happen that a woman changes her mind? Then, does it actually work? And then, is it safe? Because if on the off chance, the theoretical possibility the child survives, are we going to have and we were thinking of thalidomide back in the early 1960s. Now, will the child have severe deformities because he or she has already been exposed to mifepristone, this poisonous substance? So that was our main concern, and we waited and waited for several years before enough information. So we saw by that stage that there was close to 1,000 cases of babies surviving without any increased risk of congenital problems for the child. So it seems that mifepristone either kills the child, usually within a matter of days, or has no long-term effect. So once the initial effect of the mifepristone is counteracted or wears off, if the child survives, there isn't any long-term effects that are evident. So there hasn't been any problems for the child. For the mother, and progesterone, we know for the child causes no problems. It's been around, as I said, for about 60 years, well over 50 years. In pregnancy, it's used in IVF routinely to preserve the pregnancy in the early stages, because that's an artificial sort of pregnancy situation where the maternal production of progesterone may not be sufficient, especially in the early stages. So they have to give progesterone, even though once again there's no randomized controlled trial on this issue. But all of the obstetricians who perform IVF are very happy to give the treatment without the evidence of a randomized controlled trial to support it. So we know it's safe. Now, progesterone, I always point out to the mothers that you will experience, or you almost certainly will experience some side effects from progesterone, because progesterone, we have to give a high dose for 3 days, usually 3 days, and then a lower dose after that. So I tell them for the first 3 to 4 days, you'll be tired. So it does induce fatigue, not universally. Some of the women have had no major problems in that regard. It frequently, not always, but frequently causes nausea. So now I routinely offer them antiemetic or sickness treatment if they want to have it in case they may be sick. So we use cyclazine, which is routinely used for morning sickness in pregnancy, in early pregnancy. So we try to overcome, we advise the girls in advance what to expect. A small number of experienced headaches, dizziness, sleepiness, and nausea being the commonest. So we tell them all of the side effects, but most of the girls or the women are happy to proceed if it's a matter of trying to save the life of their child, and if they're determined to do so.
Thank you. I'm going to invite Robert to any questions you might have, Robert.
Thank you, Linda. Thank you for your time, Dr. Kearney. You mentioned the term off-license, and there's another term that is used within this wider narrative, unlicensed medication, unlicensed drugs. I think I understand the difference, but I don't want to presume that. I want to hear from you. Can you distinguish between the use of the term off-licensed medication and unlicensed medication?
Yeah, unlicensed would refer to a product that is not you're not allowed to use in this country if it's unlicensed here. Progesterone has been licensed, so it's used, as I mentioned, routinely in IVF to prevent miscarriage for decades. So it is licensed. Off-license means that, and this is the case with many drugs, particularly in pediatrics actually, and in mental health situations, I believe as well. And we're seeing more and more of it because a drug comes on, it goes through a rigorous testing protocol and various stages of testing. When somebody comes up with a novel idea that here's a condition, we have to try and find some medication or some intervention to try and deal with this condition. So they spend years and years with their research and development groups trying to develop a drug. And then eventually they come up with a drug, and then they go through various stages of trials, animal trials, and early stages of testing on humans, and usually on healthy humans initially to see is it safe, and then humans with the condition. And then it goes through lots of rigorous stages before it become licensed. And then the FDA or the licensing authority within this country will determine, yes, the evidence is robust and it's sufficient to say that this drug can now be used for this specific condition. So it's usually, most drugs are introduced with the aim of, let's say someone's had a heart attack and a new drug becomes available for the management of a heart attack. My own favorite example is clopidogrel, which is a drug that has been around since the 1990s and has revolutionized the management of myocardial infarction or heart attack. But then that had to go through lots of stages of testing before it became acceptable and approved by the licensing authorities. So once the licensing authorities are happy that the evidence is robust and sufficient, the drug becomes licensed, it can be used, it can be promoted within that jurisdiction. Many years later, it may happen that someone, usually a scientist or a doctor, will say, well, I've been using this drug for this condition, but you have a condition that doesn't quite fit, but I just wonder if I applied this drug to this condition. Or what tends to happen probably even more frequently is that patients with a number of conditions are receiving a treatment, and then it's realized, hang on, that their other condition actually seems to be benefiting from this treatment, even though we're giving it for condition A, their condition B seems to be improving. So maybe we should do some sort of investigation to see if that's the case. And then they try it on other patients and they find it works. And eventually, if it's ethical to do so, a randomized controlled trial would be the ideal way to look at that. But not always. Sometimes certainly if it's a life and death situation and there is good evidence accumulating year upon year that this off-license use is actually effective and safe in this group of patients, that the drug can become widely used. In that, so it's usually a drug that has been used for a particular type of condition, but then it's recognized that it may well be useful in a second condition. So it can be used. So it's still licensed. So the license has never been taken away, but it can be an off-license use. Now, again, you have to, if it's been off-license, it does need extra monitoring. So myself and Dr. Riley and others who've been involved in providing abortion pill reversal. We have to be careful, so we follow up. So the support that and the follow-up that we give to the women in our situation is certainly much more vigorous than what the abortion providers. They give the abortion pill, and then, as far as we know, at least in the majority of cases, they never contact the woman again, unless she contacts them with some problem.
Right.
And then usually they tell them to go to their local ER or to their GP. Whereas we, at least in my case, I contact them on a daily basis if they're happy for me to do so. And then once I realize they're out of any danger, the danger period, usually because I'm concerned about they might lose their baby or they might suffer bleeding, and I tell them that their Mifepristone will cause bleeding in almost all cases. So I prepare them in advance, but then I follow them right up until they've given birth, and then even afterwards, and I tell them they're welcome to contact me at any time if they have any concerns or any issues about what the support that I've been offering to them.
Thank you for that clarity. The term off license, is it the same as off label?
Yeah, I think the Americans use off label. We use off license, I think. But
because I'm going to quote from something in a minute, and I just wanted that clarity.
Off label, off license is the same.
So I want to look at for a few moments, if I may, a joint statement on abortion reversal, which was published by various UK medical bodies. It is undated, I noted, but from the footnotes, it's clearly within the last 5 years. And it's called the Joint Statement on Abortion, Key Points and Recommendations. I note it doesn't call itself guidelines, and it's groups including the Royal College of Obstetricians and Gynecologists, the Faculty of Sexual and Reproductive Healthcare, the Royal College of Midwives, and the British Society of Abortion Care Providers. Now, from a legal point of view, I know that guidelines don't have the same weight as legal rules, because there's a general expectation that if it's guidelines, that practitioners are meant to follow them, but there can be compelling reasons not to do so. Would you say that these recommendations have the same weight as guidelines, or are they different in nature?
They're very different, because you'll notice that all of the signatories attached to that document are all abortion providers, and they were in fact the only people who objected to the service that we were providing. I know who the chairperson of that group was the same person who was the medical director of MSI, who initiated the complaints against myself. That report, actually, that document was provided as evidence in the case against me by the people concerned, and it was looked at by the expert witness for the GMC, actually, who was a fellow of the Royal College of Obstetricians. So even though one of the signatories of that is the Royal College of Obstetricians, and he's a fellow of that organisation, he said that document was of no relevance. He said it wasn't available to the general public. It wasn't available on PubMed, unlike for example, they were criticising the George Delgado paper that I alluded to earlier, the landmark study, and they were criticising that. He said, well, at least the Delgado paper is available on PubMed, so it's available. It's a published study. This is not a published work, so it can't be considered as guidelines. It's the advice that they gave to their people working within that industry, within the abortion industry, and unfortunately that has come to pass. So since the cases against us were dropped, we have noticed a significant drop in the numbers of women coming to us. Now, I don't think the demand is less, but I think, and I know from the girls who do come to us, that they're being actively told by, whether it's BPAS or MSI or whoever they go to, that if they change their mind, they must not seek abortion reversal. So they use that as the advice that they give to their clients who change their mind.
Right.
So we don't know exactly the exact numbers who approach them and tell them they've changed their mind, but that we know from the girls who are determined enough to eventually find us, that they've already been told by these groups that they must not seek abortion reversal treatment.
Yes, thank you. I just want to read 2 sentences from this particular document, and then I have some questions relating to that. It says, good practice guidelines for prescribing and managing medicines and medical device produced by the General Medical Council state that when prescribing any, in quotes, unlicensed medicine, a doctor must be satisfied that there is sufficient evidence or experience of using the medicine to demonstrate its safety and efficacy. We strongly believe that this is fundamentally not the case for prescribing progesterone off-label in these circumstances. Now, you've already addressed the point about unlicensed medicines. It is claimed by those opposing the use of the abortion reversal treatment that a woman can experience bleeding as one side effect. I am actually aware that bleeding may also be caused by medical abortions. This is actually a fact. It's not just an opinion, of course. So is it possible to say if one is more dangerous than the other in terms of the bleeding?
It's not possible to say definitively. It's what can be said is that the aim of mifepristone is, and the abortion advocates very often, particularly among the lay population, will often use this. They say it's nothing more than 2 pills and a period. So the aim of mifepristone, the first abortion pill, is to induce a period, basically, or what they consider to be a period. Obviously, it's different from a period because there's a new human life involved rather than in a normal menstrual cycle. So, but what they're aiming to do is exactly the same. So when a woman has a menstrual period, what happens is the levels of progesterone in her body have suddenly dropped. So it's the progesterone is vital to preserve the integrity of the lining of the womb. So when progesterone levels reach a certain very low level, the shedding of the lining of the womb takes place, and that always will be associated with bleeding. So the aim of mifepristone is exactly the same. They're trying to mimic that state of a low progesterone level. There is some evidence that the progesterone levels actually do get shut down. That's more in animal models. I don't think it has been proven yet in humans, but certainly in animal models, progesterone levels do eventually get shut down by mifepristone use. But even if the levels don't drop, it creates it mimics the exact similar circumstances because the progesterone can no longer have its effect. The progesterone is a steroid hormone, and steroids exert their effect by binding to receptors. The molecules of the steroid drug or steroid chemical bind to receptors that causes chemical reactions. And that's how a lot of drugs have their effect. And mifepristone competes for these receptors. So it's pretending to be progesterone, if you like, and getting in there before progesterone. Then the body interprets that, our levels of progesterone have dropped and the lining of the womb gets shed. So inevitably, mifepristone has to cause bleeding. If it's going to have its effect, it has to cause bleeding. Eventually, it may not be immediate. And in my case, in the girls where the treatment hasn't been successful, most of them will lose their baby between day 2 and day 10. So if they get over the first 10 days without losing the baby, there's a very, very good chance that their baby will survive, particularly with continuing progesterone use. And we give it for a minimum of 2 weeks, which is actually much less than what they give it for in threatened miscarriage and in ectopic pregnancy or in IVF situations. Yeah, so mifepristone, by its nature, is designed to cause bleeding. And I always warn the girls that you will bleed. You almost certainly will bleed. The only girls who haven't bled are those who've taken it a little bit later in pregnancy. So they've taken it in, well into the second trimester. When even then, some of them will still have some bleeding, but some of them won't. And the only ones who haven't had bleeding, whether they've had successful reversal treatment or not, have been those who've been in the second trimester. So now there was, I don't know whether you were going to allude to it later, but one of the objections that later came on board is that they tried to claim, once they realized that, okay, they can't use the argument anymore that it's junk science, because there is more and more evidence increased that it actually can work. Number two, that they can't use the argument that that there's no need for it because women are crying out for this, if you like, or in many cases. So the argument that they try to portray nowadays is that it's dangerous. And that's on the basis of a single, they call it a randomized control trial. It was a randomized trial, but it wasn't a control trial, by Mitchell Kreiner, one of the people I mentioned earlier. He decided, he's the person who'd been saying for years and years that this is junk science, it doesn't work. He was determined then that, well, he can't just keep saying that without some evidence. So he decided he was going to establish a trial. This was in 2019, 2020. It was published at the end of 2020. That he was going to see once and for all, he was going to prove once and for all that this was ineffective junk medicine. Now, the first thing I would say on that is that any serious investigator, that's not how you go into a trial. You do not go out to prove something is good or bad. You go with a question, say, I wonder, would this work? I'll establish a trial. And so you design a trial geared towards that. He designed a trial determined to show that this wouldn't work. So he determined that only 40 participants would be necessary. Now, there isn't any, I can't think of any other trial in the history of medicine where you would only take 40 people, divide them into two groups. One group of 20 receives one treatment, one sees either no treatment or a different treatment, and then you compare them. If you do that, you're almost always going to show that there's no difference between them, because you won't have the statistical power to show that there's a significant difference unless one treatment is 100% effective and the other was 100% ineffective, which we've never claimed with progesterone treatment. So he was determined to show that this was an ineffective treatment. So he designed a trial for 40 women. These were women who were due to have surgical abortions anyway, and he persuaded them to just delay their abortion for about 15 days to allow them to take part in the study if they were willing to do so. So they all received Mifepristone on day 1. And then 24 hours later, they received either progesterone or placebo. And then they were going to be followed up for a 15-day period, measuring levels of progesterone, looking for complications, ultrasound examination to see if the pregnancy was still viable. Only 12 women were actually enrolled into the study, 2 of whom pulled out, 1 in each group, for personal reasons. They didn't want to just continue the study. And with any study of that, especially, there's always going to be a 10% dropout rate, at least in any study. And there's something as controversial as abortion, you can be pretty sure that there's going to be even higher dropout rates. So he was starting off at 40, knowing that it was probably going to be down to 32, 33, 34, very quickly. But he stopped it after 12 patients had been enrolled, 10 of whom had continued the treatment. So there was 5 in the placebo group and 5 in the progesterone group. They found that after 15 days in the progesterone group, 4 out of 5 women were still pregnant, which was higher than I would have expected at that stage. I would have expected slightly lower, but 80% survival rate at that stage. And in the placebo group, 2 out of 5, so 40%. So that immediately showed a doubling of the survival rate of using progesterone. They also found, looking at the serious risk of bleeding, and this is what they used to stop this, to prematurely stop the study, that they felt was too high a risk of serious bleeding. 2 women in the placebo group had serious bleeds. 1 required a blood transfusion, and the other required an emergency surgical abortion because of the ongoing bleeding. In the progesterone group, 1 woman presented to her ER department with bleeding, but she was assessed, checked out, did blood tests. Her blood count hadn't dropped. Her bleeding was considered to be not serious, and she was discharged home without any intervention. So that study, even though there was only 10 people involved in the 2 arms of the study, was already showing at a very early stage that progesterone was doubling the survival rate and having the risk of bleeding and showing no serious risk of bleeding. So, but they decided, well, 3 women have had serious bleeds. We can't continue this. It would be unethical to continue the study. And then that's the excuse that they use, and that's what they reported, that this was dangerous intervention. So that puts them in a difficult situation, because all along they have been saying that if a woman changes her mind, then all she can do is just don't take the second pill. Now that puts, if a woman is in that group, that puts her into the group of that risk of serious bleeding by not taking Mifepristone, by not getting progesterone. So they're now advocating that they're trying to show that this study shows a serious risk of hemorrhage if the woman only takes Mifepristone and doesn't follow up with the recommended Mifepristone or doesn't get progesterone. Whereas we're saying a woman has 3 options. If she's taken the first abortion pill, she now has 3 options. She can do nothing. She can do what the expectant management, as the RCOG and others have recommended, but there may be a risk now. Again, 6 people or 10 people in the study, you can't extrapolate to say that's going to be that's a universal risk that's going to be taken. That shows how dangerous APR is, and we can turn it back on them and say, well, actually, it shows the opposite of what you're saying. So a woman has 3 options. She can either just do nothing, just wait and see what happens, which we advocate is not a good thing. She could go ahead and proceed with the abortion, and some do. Almost a third of them that contact me eventually do. and that will still cause bleeding. And in some cases, there have been some deaths, there have been serious infections, there are serious complications. And a study done by a group called Percuity a number of years ago during the COVID lockdown found that there were thousands and thousands of women being, now not all of them would have serious complications, but thousands. So roughly 7% of women who take both abortion pills will end up having emergency attendances in their local A&E or ER departments. That's a huge number when you take that, that 250,000 women have abortions and 235 to 40,000 of those are chemical abortions. So you're going to get tens of thousands of women every year attending casualty services because of serious, or at least what they consider to be serious complications related to taking both abortion pills. The majority is because of bleeding, some because of severe pain that just can't be controlled, and some because of serious infections. And there have been, I'm sure you're aware, there have been a number of tragic deaths of young women whose lives could have been saved if interventions had been carried out sooner, if the severity of their illness had been recognised by infection or by severe hemorrhage. So that's the second option that women have, is that they could take the second abortion pill. And the third option which we offer is that they could try to save their baby if they're determined to do so by having progesterone, possibly reducing the risk of, we don't say that definitely reduce the risk of bleeding, but a little bit of evidence we have suggests that certainly if it's successful, the risk of serious bleeding is reduced. And even if it's not successful, there's a possibility that maybe we've reduced the risk of bleeding, as demonstrated in that very, very small study that the people opposed to APR, abortion pill reversal, tried to use against us. If any sort of independent person who would look at the actual data from that study could come up with a different conclusion. In my own opinion, and again, I have no way of proving this unless one of the authors of the study comes out and states it otherwise. But my own opinion is that I think that trial was stopped because the authors didn't like what it was already starting to show. That because they were determined to show, and they had publicly written about that, we are once and for all going to show that this is junk science, and by proving it with this study. And even though they only had a small study designed, it was already, even with the small numbers, it was already starting to show that there was certainly something happening of benefit to the women who had taken the progesterone compared to those who had taken placebo. I believe that but it is only my personal opinion, that they stopped it because they did not like what the early stages of that study was already starting to determine.
Thank you for that very detailed explanation. I have about 2 or 3 brief questions. I'm just mindful of the fact that there will be others who want to ask questions as well. You referenced earlier what is going on in the United States, that there are thousands of babies being saved, and you said in this country 75 babies, as far as you're aware, have been saved. How many of those have you been associated with in terms of your assistance?
33 births so far, 2 more on the way. One girl is around 19 weeks. She's just gone up to 20 weeks, and the other girl has just passed. She had her 12-week scan 2 weeks, so she's about 14 weeks at this stage. So that'll be hopefully 35. There have been many others that have been tragic. Some of the girls have got to, well, one girl last year, or young woman, got to 18 weeks. It was doing fine. So she was 10 weeks past the danger period, and then unfortunately her husband persuaded her to have an abortion at 18 weeks. And that's happened a few times. That was the latest stage of pregnancy that's happened. But others have gone well past the danger period. Because if we can get them to about 4 or 5 weeks, if we can get them into the second trimester, if they've taken the abortion pill in the first trimester, and we can get them to 4 or 5 weeks after they've taken, so 28 days after they've taken the Mifepristone, and if they've taken the progesterone that time, if they haven't lost their baby by 28 days, it basically becomes the same risk at that stage of losing a baby as with any normal pregnancy. And there's still a 1 in 10 chance, possibly in the early stage of pregnancy, that a woman, and maybe even more, we don't know the exact risks of miscarriage in early pregnancy for normal pregnancies. So we do have to sometimes console the mothers that they've done everything that they could, that the effect of the Mifepristone was long gone, but unfortunately it wasn't to be, that the baby maybe died at 14 weeks, 15 weeks. Even though they've taken the abortion pill at 6, 7 weeks. Now, we can't say that our treatment has been successful, but the evidence would suggest that the treatment has been, if they've managed to get past that stage. So 33 babies have definitely been born that I know of, and 2 more on the way, 35. And then my colleagues have various numbers between them. So I'm aware of 75 with some, certainly in my own case, 2 more, and at least another 1 or 2 in some of the other providers as well.
Yes. The contrast between what is going on in America with regards to abortion and specifically abortion reversal treatment and what is happening here in the UK with regards to pro-abortion doctors and their beliefs, you couldn't get a sharper contrast. Would it be safe to say that globally, given that there's no consensus on this issue of abortion reversal treatment, would it be right to say that medical opinion is simply divided? Would that be a fair way to describe it?
Oh yeah, very much so. And well, it's divided among those who have looked into the situation. The vast majority, I would say 95% of the medical field know nothing about, absolutely nothing about this. Even many, well-experienced obstetricians and endocrinologists this is actually an endocrinology issue rather than obstetrician, but it's would not know anything about it. And as I said, we knew nothing about it, even though it had been around for a number of years. Us, we're reasonably experienced physicians within the Catholic Medical Association. None of us had never heard of it by 2014, and even by 2018, we still were very unaware of the issues involved until I went over to meet the people and to attend conferences and read everything I could on the issue. Actually, I probably should point out that the thing that convinced me most, the article that I came across that made me decide, yes, we need to do this, was actually in 2018. 2017, New York Times, which again is not a renowned pro-life sort of newspaper, but there was quite a good, well-balanced article written in the New York Times looking at the whole issue of abortion pill reversed, and they called it the new front in the war on abortion or something. And it interviewed George Delgado, it interviewed the Daniel Grossman on both sides of the argument. It interviewed some of the women who had been involved. But the person that convinced me most was a professor of reproductive health and placental research at Yale Medical School called Professor Harvey Kleiman. And he described himself as being pro-choice, but he obviously knows something about progesterone and placentas and pregnancy. And his opinion was this makes absolute biological sense. He said there's definitely a firm scientific basis to this. And he said, if I had a daughter and she was pregnant and she took Mifepristone by accident or wanted to save her baby, I would give her progesterone straight away. And he said, and I'll tell you something, I bet it'll work. So in someone of that caliber and that background was convinced that this was something worth pursuing, that was the key factor that made me decide, yes, I need to look into this more seriously.
Okay, thank you. The last question I have, the joint statement I referred to earlier cites a piece from Open Democracy as part of its case that claims abortion reversal treatment is dangerous. And the very same article from Open Democracy is cited by the political advisor to the president and chief executive of the Royal College of Obstetricians and Gynecologists in his letter, a copy of which you sent us. Now, Open Democracy describes itself as an independent international media platform whose members include the BBC, the New York Times, the Daily Mirror, the Guardian, amongst other outlets. So I've been thinking about this, Dermot. When the medical profession makes its case public about such and such treatment being safe and effective or not, one doesn't expect journalist outlets to be quoted as authorities. The practice of citing journalist outlets as authority in support of public, professional, medical positions is odd to my mind. Which of the following options, I've just thought of 2 options here, best describes, in your opinion, the use of journalistic authorities in support of formal, professional medical opinions? Is it never done, or is it occasionally done?
I would say never done. I'm not aware of. I certainly wouldn't expect authorities, medical bodies to use those sources. Sorry, am I understanding what you're asking?
Yeah.
Yeah.
You've confirmed what I
Yeah.
thought myself. I just wanted your medical view on that.
Yeah.
I know that you're going to cover later on in our hearing the protests, because I have some questions about that in terms of what happened at Manchester University, but I will pause it for now. Thank you so much for answering all those questions. Back to Linda.
Thank you.
Thank you, Robert. Nina, can I invite you to put your questions, please?
Yes, thank you, Linda, and thank you, Dermot, for your detailed account so far. I think most of my questions will actually relate to what comes after this more medical, technical discussion, but I just wanted to ask a kind of broader question about how you see the sort of presuppositions of medicine perhaps shifting, because in your account you correct me if I'm wrong, but the original idea was sort of more based on women's consent, and perhaps this idea that if a woman has agreed to something, then she either can change her mind or not, to more pushing the idea of danger and risk. Of course, you're saying even on those grounds, the critical account doesn't stand up, because actually you have what limited research has been allowed to do actually is more on your side, right? Rather than the idea that this progesterone treatment is it's dangerous when it's not. And then obviously, as you say, it's already been used to aid with prevention of miscarriage. In the time you've been practicing, would you describe that shift from more of a model of a kind of consent to something like an emphasis on risk, or is that not accurate?
It's accurate in the term. The only people who have shifted in that regard are those who are opposed to what we're doing. Like for us, our only concern is responding to the request and to the needs of women in this situation, this tragic situation in many cases. And that's the only reason we do it. We didn't decide one day, how can we impose our Catholic or our Christian beliefs or our pro-life beliefs on women? What group out there can we take advantage of? They came to us. That's why we started. We were reluctant to get involved initially because we didn't know much about it, but we decided because of the demand that was there. And if the demand ceased, I would very happily sort of stop providing the service. If women, like I don't go out looking for women. I do try to create awareness of it, because I think that's part of the problem, is that people are not being aware. So, for example, if you, and I used to do this before, back in 2020, 2021, when we started providing the service, if you put in abortion pill reversal on an internet search, you would get abortion pill reversal, you would get the various groups who are promoting it, you would get the helpline that most of the women, about 80 to 90% of the women who come to us do so through a Google online search, and they put in abortion pill reversal. Now, if you put in abortion pill reversal, you get statements from Open Democracy, EPAS, MSI, Planned Parenthood, the RCOG, the American College of Obstetricians, all who are opposed to. So you get their propaganda, I would call it, saying that this is dangerous, do not touch it. And you have to really go far down, and it's surprising that actually the women who do find us, that they do manage to get the message, because they would have had to trawl through these negative comments made on it. So you have to actually get the website, you have to put in abortionpillreversal.com. So I try to create awareness on social media, and people that I come in contact with on the various pro-life groups to, and also then the fact that, with the buffer zones in this country, some of our clients, I think, came to us, some of the women who came to us did so on the basis, not many, but a small number, because of information that they received from some of the people witnessing outside or offering help outside of abortion clinics. And they could contact us directly without having to go through the helpline as such. So the shift has been only on the other side, and as initially their only objection was that it wasn't necessary. Then it became that it's young science, and then on the basis of the Mitchell-Crinan study, they're trying now to say that it's dangerous. But I don't know what they're next. And then it becomes a personal issue where they personally attack the people involved, and that was what eventually led to the case being brought against myself and Dr. Riley.
Sure, thank you. That's all from me for the moment. Thank you.
Thank you, Nina. Peter.
Thank you very much, Linda, and thank you, Dr. Kearney, for appearing here today. I'm just aware that we haven't yet heard the account of what happened at the University of Manchester. And my questions relate to, I think, both that and so in the round with regards to the proceedings of the GMC et al. So would it be an appropriate time now, Dr. Kearney, for you to just describe that, give a very concise account, if you could, of that? And what I'll do then is ask questions based on that and what's had come before, if that's all
Peter,
right.
can I just intervene here because James might well have some questions actually relating to what Dr. Keane has already shared. So can we just go? I mean, we will come to this, but I don't want to prevent James from asking any questions he might have.
Well, if you'd like me to segregate the questions that I have with regards to this, because I mean, effectively, I think they touch on both, but I'm very happy to wait until the end if you prefer, or I can ask the ones that relate to the GMC now. But I think again they touch on both.
Maybe keep them in that case if they're going to touch on both, Peter, because I think that will sort of, slot it together. It may be that James doesn't have any questions on this, but Jamie, if I could go over to you, please, and see where we are.
To me, did you say?
Yes, please, because Peter's questions relate specifically to the
Sure. Okay.
demonstrations.
Okay, I have some questions on Manchester as well, obviously. Doctor, thank you very much again for coming and for being so forthright and articulate in what you've said. I'm going to ask you some questions in this format simply by putting to you what we have in the evidence or the evidence that we've been given. So don't feel that you need to repeat what you've already said. If you've already said it, then you can say, well, I think I've answered that. That will save time. But I would like to put it to you so that there is an opportunity for you to comment on anything that you may not already have commented. So my first questions were about Manchester, so I'll just move on from that. Pardon me for a moment. Linda, I'm assuming that the Manchester issue also embraces the statement from the Royal College. So I'll leave that till later.
Yes. I mean, would it be helpful at this point to actually ask Dermot to just run through briefly what happened with the Birmingham and Manchester incidents?
Okay.
Yes, certainly.
So
If
yeah.
that would suit me and clearly Peter. If it suits others, then yes, please do.
Okay, let us do that then. Thank you. Dermot, please.
So since my case received some publicity, I received a number of invitations from mainly within this country and also internationally, but within this country it's mainly from some of the pro-life students groups that have been established in some of the universities. And the first one I went to actually was in Oxford, and there was absolutely no problem there. There was a small group. I told them the story. I think that might actually have been before the case had been fully finalised, while it was still going on. But then the one that came to attention was with the Birmingham. I was invited. I can't remember the exact date. I think it was probably 2022. So not long after the case had been dismissed against us. Could have been 2023. I was invited by the pro-life group in Birmingham University to tell the story of abortion pill reversal within the UK. I usually entitle my presentation in this area as offering women a second chance. That's what we're doing. We're offering women a second chance. The abortion pill reversal in the UK. And unknown to me, I'm based in the northeast of England, I was driving down to Birmingham on the day of the alleged prepared meeting. I didn't know that there was going to be any protests. I didn't expect that there would, because I had been to, I said, Oxford and possibly one other university before that without any problems. And only when I got there, when I was met by one of the students, he said, we have a little bit of a problem. We almost had to cancel the meeting because there was a letter of protest, which I think I've supplied, that was signed by a number of groups within the university, groups that were opposed to allowing me to speak to people on campus on this issue. And I said, I've no problem. People are very welcome to come to the presentation, and I'm very happy to answer any questions that they may have. And he said, no, you don't understand. We had to cancel it because there was a threat that there might be, serious protests. But he said, luckily, we got it reinstated. They had to go through a rigorous process where they had to cancel the meeting and then reinstate it, but make it ticket only. So the only people who could attend were those who had a ticket, which were issued, and there was a limited number of tickets. So he said, but you will find that we have the meeting in the room, but there will be some protesters outside. I said that's fine, as long as they don't interrupt the meeting or prevent me from, giving the presentation that I intend to give. And then that was okay. There was a security man present. He ensured that there was no physical violence or loud protests. And then I gave the presentation, which was about 45 minutes or so, with maybe a little bit of questions afterwards. And then there was a small group of maybe 20 people outside the meeting room who approached me. And one of them, respectfully, she was a nursing student, and she said she had concerns. She wanted me to ask some questions. I said, absolutely, and that's why I'm here. I'm very happy. So they asked some questions about the treatment, much like of what you've asked today, about the safety, the efficacy, the numbers of women involved. And I answered them, and they were surprised. They were surprised that I wasn't the demon that they maybe tried to portray me to be. I think the nursing student, actually, while she didn't agree with my stance on abortion in general, she did, at least was respectful enough to thank me for the responses. One or two of our colleagues were a little bit more vociferous and demanded or were trying to make allegations that weren't true and trying to accuse me of lying. And I tried to hold peaceful and respectful conversations. But I find that once with these groups, once you provide in a respectful and calm manner the actual truth, or at least raise the right questions to challenge whatever allegations they're making against you, they tend to back off. They don't want to hear anymore. So once you answer their questions, they basically turn their backs and then walk away. They don't see reason, or they don't want to see reason, at least at that point. Maybe my hope is always that people who are maybe not prepared to engage in a respectful, reasonable manner will maybe somewhere down the road will reflect on the episode and maybe reconsider some of the points. So that was Birmingham, which was okay. There was no major protest, and the meeting went ahead as planned with some protesters asking questions afterwards, which was fine. I was also surprised that the Birmingham Students' Union actually sent. I got a check for my travel expenses afterwards. They asked me to provide the receipts for travel, and I did, and I got the travel covered, which was very welcome. I think because at that stage, I think the universities were very keen to not be accused of cancelling invited speakers by their group. So they were keen to do everything they could to show that they were open to opposing voices being heard on their campus sites. Manchester was this year. I had heard from last year, there was reports that when they established initially the pro-life students group in Manchester, there was horrific opposition to them, and young girls being threatened with violence and with rape who were attending the first meeting. And they were very courageous young students, and with a very loud mob. Most of members of the mob were probably not students actually within the university, but were recruited to come in to protest against a pro-life group being established. So earlier this year, that same pro-life group, which I didn't know they were still in existence. I thought maybe they had to disband because of the opposition to them, but they were still going strong and had held a number of meetings. They invited me to come and speak to their group at the end of March, the 28th of March, which I said I was very happy to do. And then 1 or 2 days beforehand, I received a WhatsApp message from the organizer, Inga Botha, who was the president of the Pro-Life, and she was the one who was particularly subjected to hateful remarks in the early stages of the group's existence. I received a message from her to say that there may be a little problem, that they had noticed that posters had been put up in Manchester, not only within the university, but on the public streets of Manchester, demonizing me. They had my face that they'd taken from an internet search and made it red, looking like a satanic or a demonic figure, and they put in to say that I was a misogynist, spreading hateful information that was dangerous to women. and that this speaker must not be allowed to speak on campus in Manchester, and we're inviting people to assemble at a certain point so they could voice their protests at that time. I didn't think too much of it. I thought, well, we had something similar in Birmingham. I'm sure the university will stand by us, because this is a legitimate group within the students' union. They've had worse times when they were initially established. I spoke to one of my colleagues, Rachel McKenzie, who works with Rachel's Vineyard, another group that helps women who regret their abortions, post-abortive sufferers. And she had been invited to Manchester. She gave a talk and she said, "Oh, it was no problem. There was no opposition. Everything went fine." So I presumed that something similar would be the case for me, even though Inga had pointed out there might be a little bit of an opposition. And then when we got there, the meeting was scheduled to take place at a designated time in a designated room within the university campus. And there was, I don't know, maybe 70 to 100 protesters outside, all chanting, and most of them wearing masks or balaclavas. Some of them had banners with various slogans written on them, but they were blocking the entrance to the meeting room. There was some security people there. There was 2 police officers there, at least initially, and I was later told there was 2 plainclothes police officers standing a little bit further away. So there was between 2 and 4 police officers. There was some security members. One man came up to me, I didn't know who he was, and he said, he introduced himself and he said he was with security, and I said, what's your role here? He said, well, I have to go wherever you go. So he was there for my personal protection, which was nice. I said, well, I probably don't. I said, I'm Irish. I probably don't need personal protection. But he said, well, I'm Irish too. He was from Liverpool. So he followed me more or less to make sure that no harm came to me, I presume. But we thought that the police would help us to get in, because three of the members of the group had already gone into the building, and they were waving from an upstairs room at us, but we couldn't get in because there was 3 or 4 rows of people blocking and we couldn't force our way through. So we thought the police would ask them to step back and let us in, but they didn't. They initially told us, or they told someone, that they were waiting for reinforcements to come. I don't know why police would need reinforcements against students who aren't heavily armed, but we waited and waited, and eventually, after about an hour and a half, nothing was happening. I think it was the police, either police or security, advised that we wouldn't be able to hold the meeting in that building, that we'd have to cancel it. So they asked if I would be happy to, if they found an alternative site, which was off campus, and we did. Initially we went to one place which wasn't available, but then we went to a second. Eventually we found a place not too far away from the university where we had a meeting just among, there was about 13, 14 people had stayed for the meeting. Interestingly, two of the protesters tried to mingle with our group by following us, but it was then that the plainclothes security people intervened at that stage, because apparently you're allowed to protest, which is fine. You're allowed to block. I didn't know you were allowed to block entrance into public buildings that have been designated for meeting places, but that seemed to be the case, that the police weren't prepared to do anything about it. But when it got to the stage of following us or walking with us, that was considered harassment. And then the 2 people concerned were taken away, and they weren't allowed to follow us to wherever we were going. So that was considered harassment, whereas all of the other, what went before, wasn't considered harassment, even though they were chanting lots of pretty hateful slogans, but some of them personal against myself, some of them against pro-life people in general, and obviously the usual anti-religious, anti-church sort of, not the church, not the state, or except with more expletive language than that. Keep your rosaries off our ovaries. So it's a typical sort of chance that you get at most of these types of demonstrations. So we went ahead, we held our meeting. We were a little bit delayed, so it meant we got out of Manchester quite late. But I believe, I don't know for certain, but Inga told me that ADF International are looking into this issue, and also the union of the Free Speech Union, I think, are being asked to become involved as well. But I haven't heard if there's any latest developments on those. They didn't pay my travel expenses either, at least not yet, even though I put in, I submitted my receipts, my petrol receipts for travel, but I haven't received anything from Manchester yet, unlike Birmingham.
Thank you. My goodness. Peter, let us go to you first and then to Jamie.
Thank you very much, Linda. And again, thank you, Dr. Kearney. So the question I wanted to ask, just based on everything that we've heard so far, is please could you connect, this is the Commission investigating discrimination against Christians. Please could you just connect for the record your beliefs concerning abortion to your Christian faith?
Yeah, it was not only my Christian faith. Like, even if I wasn't a Christian, I would I know from a scientific point of view, from a medical point of view, that every human life begins at the time of fertilization. So it doesn't begin at birth or at sentience or with a heartbeat. It begins at the very beginning, which is at fertilization. I believe, whether it's a Christian belief or whether it's just a humanitarian belief, I believe that all human beings should have rights. That we all have inherent value. It's because of the very fact that we're human. It's not dependent on our sex, our race, our ethnicity, our abilities, our age, our size, our color, but it's inherent, the very fact that we are members of the human race. So I know that human life begins at fertilization. I believe all human rights have equal inherent value. So I'm opposed to the intentional destruction of any human life from conception at the time of fertilization to natural death. So I don't only oppose abortion, I oppose euthanasia, I oppose unjustified, and there are very few, apart from self-defense and maybe war situations, oppose the death penalty. Even though I can understand why some, in some situations, may not oppose it, but as a Catholic and as a Christian, I would oppose the death penalty. But even if I wasn't a member of the Christian faith, I would hope that I would still hold those same beliefs and views on the value of human life.
So would it therefore be true to say that you have a philosophical and religious belief, to use the terms of the Equality Act and protected characteristics?
Yes, I think that would be a fair description.
And would you say that you are particularly motivated on this issue because of your faith as well, as a Catholic, as a Christian?
Yeah, that certainly helps. But I've often said, like, sometimes when I've been accused, usually on social media, of you're enforcing your Christian beliefs, but I often say that, well, if the Catholic Church, and I know that this definitely won't happen, but if the Catholic Church came out tomorrow and said, we know we were wrong, we believe abortion is I said I would no longer be a Catholic. So to some extent, my humanitarian or philosophical belief would even come before my Catholic belief. But I'm very pleased that my church supports what I inherently believe anyway.
Right. So your philosophical belief is supported by your religious belief, which coincides with it.
Absolutely, yeah.
That's great, because that, I think, establishes the kind of context in which we're approaching these kind of questions. And so that motivates, therefore, your actions with regards to abortion reversal.
Well, it does, and it also, as a doctor, like and as we wrote to the GMC, if a patient comes with requesting help with a specific condition, how should we respond? And they said, well, you use the knowledge that's available to you in a respectful manner, which is what we did. So my abortion reversal came about because I was a member of the Catholic Medical Association. But even if I wasn't a member of that organization, if I had come across it, I would like to think that, if I had heard that this is a valid treatment, it's been well validated, even if not recognized by many of the sort of official medical professional bodies, but still recognized by some. So it's not universally ignored or protested by medical. So some medical organizations, reputable organizations, strongly approve of it, with reputable people involved, and not necessarily only Catholic or Christian. So I would hope that I would at least promote it. The reason I got involved is that nobody else was doing it. We saw that this was a need. Nobody else was addressing it. We tried to the best of our ability to encourage the medical authorities in this country, particularly the Royal Colleges of GPs and obstetricians, to offer this service to women, and they wouldn't do it. So we couldn't just say, well, we can't. Unfortunately, but for the 9-month period or 10-month period when we weren't able to provide, that's exactly what happened, because women still, and every month I got a notification from the abortion reversal helpline telling me the numbers of women that were coming to them. Now, some of them may have been journalists, some of them may have been fake ones just trying to find out were we still doing this, but there was genuine requests, and they unfortunately had to tell them, we're very sorry, but at this point in time, there is no doctor in the United Kingdom able to provide this service. So that's what we're doing, where we're responding to a need that's there that nobody else so far has been willing to provide.
Thank you. I think we would all like to think that we would always, under every circumstance, be completely objective about medical issues and the like. Would you say that your ethos, sort of anti-abortion ethos as a Christian and as somebody who has a humanitarian basis that coincides with your faith, gave you a better understanding, or rather a better motivation to promote this treatment than would be someone who actually was ambivalent or even pro-abortion?
Probably.
Yeah.
Again, you can never say, because I've been a Catholic, a believing Catholic all my life. So I presume it has had some impact on the way I view the world and the way I view the care of people and healthcare provision,
Brilliant.
which I
So
think
would
is
you say,
a positive thing, I think.
would you say that your case, and if so, would you please itemize the particulars within your case, both in terms of the way you were treated professionally within the GMC et al., but also with regards to, I think it's more obvious, with regards to the university affairs, how discrimination has taken place against you because of your anti-abortion ethos and the consequent actions you've taken as a medical professional to promote a better choice for women, as you might put it, with regards to abortion, chemical abortions and the reversal thereof?
Yeah, well, I think it's pretty obvious that it's like the reason that the complaints were brought against myself and Dr. Riley was that because of our pro-life stance, and that they were the specific allegations. Most of the specific allegations were related to our pro-life activities. In Dr. Riley's case, it was pointed out that she had given, and then also the MSI drew attention to the GMC that I had been involved in, giving presentations at pro-life meetings. So yeah, the allegations brought against us were directly because of our pro-life beliefs and our pro-life activities. What was specifically in relation to Christian beliefs, what was disappointing was the allegation from the Royal College of Obstetricians, which surprising that they actually put it in writing, but they said specifically that they weren't concerned so much about the treatment we were offering, but it was the people involved, and because they highlighted that we were Catholic. And one of us happened to be the president of the Catholic Medical Association, which was apparently an even bigger crime than just being a normal, regular Catholic. So that was disappointing. And it was disappointing that was actually endorsed by the GMC. Like, the GMC didn't have to. They could have rejected, said, well, we don't agree with that aspect. We do agree that there are other issues that need to be addressed here, but the fact that he's a Catholic should have no bearing on this. So it was disappointing that was endorsed by the GMC and used in their evidence at the tribunal against me. We later, because it was a 3-year term, so by 2021 there was a new president elected, Mike Delaney, and he wrote to the GMC because I raised the issue I didn't mention it earlier, but I didn't think it was that relevant, but the GMC had established an Equality, Diversity and Inclusion Forum, strategic forum, just a little bit before COVID, because I know I went to 1 or 2 meetings where we didn't have to wear masks or anything. And so around 2018, it must have been, because I was just elected president of the CMA. So 2018, 2019, and it was all groups. There was a number of faith groups, so Jewish doctors, Muslim doctors, Sikh doctors, LGBT doctors, disabled doctors, women doctors, surgeons, lots of sort of any ethnic minority, African doctors, invited to take part in this, because the GMC was trying to portray that it had been accused of being a racist organization. I was trying to portray that this was not the case, and that it welcomed all these minority groups' input. And at each meeting, we were asked to give an account of some of the activities of our groups. And at the meeting in April, so just literally 3 weeks before I received the notification from the GMC of the allegations against me. So at the start of April, I attended a meeting and I gave a report to say that a number of our members were involved in providing abortion pill reversal treatment to women who were trying to save their babies. And I gave a brief account of that. And I said at that stage we already had saved a number of babies, and I gave the numbers. And at the end of it, the chairperson of the group said, "Thank you very much, Dr. Kearney." Now they moved on to the next group to give. So the GMC were aware of this, and yet it was disappointing that they came out and that they endorsed the allegation that because of my Catholic background that I that I may well be guilty of professional misconduct in trying to enforce my Catholic beliefs on these vulnerable women. So Mike Delaney then wrote to the GMC afterwards, raising this issue, and it was just brushes. I don't think they fully understood what, because they thought he was complaining that two of the members of CMA were being investigated, which that wasn't the complaint. Was that we were specifically concerned about the fact that our Christian beliefs was mentioned and endorsed in the allegations, and they totally ignored that and just brushed. So we were going to follow it further, but we thought we don't have a lot of respect for the GMC. There is a degree of incompetence, and we felt that we could keep arguing this or trying to highlight this issue to them, but they probably wouldn't understand it. So we decided we weren't going to pursue it any further, because by that stage the case had been dropped. This was into March 2022 by the time we got a response from them.
Thank you very much, Mr. Kearney. I'm very aware of time, so I'm going to leave it there. Thank you very much for all your contributions.
Thank you.
Thank you, Peter. Jamie. You're muted, Jamie. Still muted.
Sorry about that. Can you hear me now?
Yes, thank you.
Yes, as I said, thank you very much, Doctor, for coming to answer questions. And what I'm going to do is just have a look at some of the evidence that we've been given, which of course you're very familiar with, since they were used in the proceedings against you by the GMC or before the GMC. And you don't have to repeat anything that you've said already. If you've already commented, then we can leave it at that in view of time. But I do think it's important to put them on the public record and give you an opportunity to comment further if you feel you need. And as a starter, there's an open letter entitled "An Open Letter Against Allowing Dr. Dermot Kearney Speak on Our Campus." They seem to have left out the word "to," but never mind. It is subheaded equally illiterately, TW, Abortion and Anti-Abortion Descriptions and Mentions. And it is signed off by groups and individuals, including Women in Politics Committee, whatever that is, Intersectional Feminist Association Committee, whatever that may be, Students for Choice Committee, which seems a particularly ironic in view of the circumstances of your case, Reclaim Campus Committee, not sure what that means. Perhaps they think the campus needs reclaiming if people like you come to it. Birmingham University Labour Students Committee, Lib Dems Committee, Women in Medicine Committee, and a number of individuals. And it begins by stating, "We are speaking out as societies who are deeply concerned with the Students for Life Society, who have invited a speaker tonight at the Guild of Students who purports and spreads false and unscientific treatments." Once again, semi-literate. But let that be for the moment. And it begins thus: "They've invited Dr. Dermot Kearney to our campus to speak. This is a person who provides progesterone abortion reversal pills, which are not medically regulated. Regardless of views about abortion, there is no doubt that a speaker who is being promoted with his pills, which are not clinically regulated, is someone who should not speak on our campus." What do you say about that statement that you haven't already said?
Well, it's coming from a position of ignorance, and then that became clear because I presume some of the people who signed that letter were those very same protesters who were. This is the Birmingham situation, which was actually quite more respectful, as it turned out, than the Manchester, even though one or two of the individuals were a little bit loud and didn't engage in quite a respectful manner, the way that one or two of their colleagues did. So it came from a position of ignorance. So that's why, I didn't know about that letter until afterwards. And until I arrived, I didn't know there was any opposition to me coming to speak at Birmingham. But I do realize that the people who are signing those types of letters are coming from, they've been fed basically the propaganda from groups like Open Democracy, but without actually looking at the facts themselves. So these are people come from a position of ignorance who absolutely know nothing about the issue. And I have to, for that reason, I sympathize with, I have pity for them or sympathy for them. And that's why any of the presentations I give, I would be very, very happy to always meet with people in that situation, if they're prepared to at least hear my side of the story. And then, at least a small number of individuals did so in a reasonably respectful manner in Birmingham. So the statements that are written are untrue, but they're based on propaganda they've received from elsewhere without trying to establish the facts for themselves.
Specifically, they say, what do you say about them saying his pills which are not clinically regulated?
Yeah, well, that's well, they're not my pills.
Pills are progesterone, which is clearly clinically regulated.
Yeah, clinically regulated. It's licensed treatment. It's been pretty well validated, and I try to point out it took me 6 years of research into this, of looking at the evidence before I decided, yes, this is a service that I feel I can and should offer to women who request it.
I mean, what I'm getting at is that it's just factually wrong, isn't it?
Yeah, it's wrong.
Abortion reversible pills which are not medically regulated.
So it's wrong, but it's because it's just feeding from the propaganda that they've read or heard from others about us, like groups like Open Democracy would be.
It is actually false.
It's false, yeah.
Yeah,
of course.
It goes on to say, the Royal College of Obstetricians and Gynecologists, the Faculty of Sexual and Reproductive Health Care, the Royal College of Midwives, and the British Society of Abortion Care Providers published a joint statement on this, where they stated there is, quote, no reputable evidence, unquote, in the use of progesterone to, quote, reverse, unquote, an abortion. There is a lack of evidence for not only how effective it is, but the side effects which come with these unregulated pills. People who push, their word, these are not associated with NHS services which provide unbiased, non-judgmental and life-saving healthcare. They will not be able to discuss the full range of their options, and vulnerable people who need and deserve an unbiased and confidential access to healthcare. Anything you want to add to what you've already said about?
No, again, it's just false allegations, which I think I've addressed in the other questions.
When they say no reputable evidence in the use of progesterone to reverse an abortion, given what you've told us about research, particularly in America, again, is simply a false statement, isn't it?
It's a false statement, and also I would highlight at this stage that the two expert witnesses in our case, on both sides, on our side and on the GMC side, both accepted that there was evidence. They said it wasn't entirely convincing because it didn't have the randomized controlled trial evidence to support it, but they said there is evidence to support it, and therefore they felt that allegation that we were given treatment that wasn't evidence-based on both sides of the argument, both of them agreed that this was not the case, that there was evidence. Wasn't the evidence that they would like to see, but it could not be said there was no evidence to support what we were doing.
They then go on to say this: the Guild does have a freedom of speech policy, and we should have free and fair debate on our campus. However, there are parts of the policy which states that, quote, unacceptable risks to the health, safety, or welfare of employees, students, or visitors, unquote, should be a consideration for when a speaker is checked to speak on campus. Progesterone abortion pills this speaker promotes have been fact-checked by organizations such as the RCOG, in other words, the Royal College. Additionally, the American Pregnancy Association states that, quote, progesterone therapy, when given improperly, can cause damage to some of the body's main systems, including the nervous, cardiovascular, and endocrine systems. What do you say about that?
Well, I'd like to see the evidence for that. Maybe given maybe in poisonous doses, that's possibly the case. But we were offering the standard recommended dose that's used that has been used for decades, tried and tested safely for prevention of miscarriage. So we were using, in fact, lower doses because we were only given the high dose for 3 days and then a lower dose for 2 weeks or a number of weeks after that, but not for the duration that's usually recommended. So we were actually using lower doses than what is currently recommended by groups such as the RCOG for prevention miscarriage. So they certainly couldn't claim that the doses of the product we were using were dangerous in any way to the mother concerned or to the child. There's no evidence to support those allegations.
And it therefore follows from what you say that it simply cannot be true that their conclusions arise from being fact-checked by the Royal College.
No, I think if the Royal College saw that statement, they would not support it.
They would repudiate it. Yeah,
they would probably put their own spin on it, but they would not say, "Oh yes, we fact-checked. This is entirely true." Because then, if they did, they would have to stop giving progesterone for miscarriage prevention and for IVF. So that would ruin a lot of their reputations and businesses.
They then go on and say, a speaker who pushes, again their word, these harmful and unscientific pills, again their words, which have not been tested should not be on our campus. People deserve fair and free access to abortions, which tends to give away the point of view that they're coming from in the first place, I would suggest. He has the potential to harm those personally affected by the issue, and also spreading false science may have severe ramifications for the health of people who may be persuaded to take something that has not been tested or regulated. There is a difference between freedom of speech and difference of views, and promoting and pushing harmful and unregulated treatments which have the potential to adversely affect the health of those who take them. Anything to add, or have you covered that?
No, I think I've covered that. So again, they're coming from a position of knowing nothing or very little or nothing about the facts of the scientific facts and the real life facts, as well as have been experienced by people like myself and others over the last 13, 14 years.
Some references are provided at the bottom of the statement, which I presume you had a chance to have a look at. The first is a non-existent reference. There's nothing there except the statement, there was a problem not available to view, so we needn't trouble ourselves with that. The second is a statement from the Royal College claiming that, quote, there is no reputable evidence, unquote, for progesterone use in abortion reversal, unquote, say medical organisations. And it goes on to say this. The Royal College of Obstetricians and Gynecologists, the Faculty of Sexual and Reproductive Healthcare, the Royal College of Midwives, and the British Society of Abortion Care Providers, obviously the same organisations that were referred to by the university, have published a joint position statement saying there is, quote, no reputable evidence, unquote, in the use of progesterone to reverse, unquote, an abortion. It comes after recent reports found that some doctors in the UK are prescribing progesterone to women in order to reverse a medical abortion so that they can continue a pregnancy. A medical abortion involves taking two different medications to end a pregnancy, Mifepristone and then Mifepristone. So-called abortion reversal treatment involves prescribing doses of progesterone after a woman has taken the first medication, Mifepristone, with the objective of reversing the effect. The organisations state that there are no reputable national or international clinical guidelines that recommend the use of progesterone to reverse the effect of Mifepristone, and no evidence that it increases the likelihood of pregnancy continuing. Well, you've already commented extensively to say that that is simply not the case medically. Is there anything you want to say about those particular organisations?
Those particular organisations, yes, because those statements and that particular document produced was, looked at by the case investigators, the expert witnesses, particularly in our case, and both of whom rejected that has been of relevance because it was obviously a biased piece. Just as we could easily produce a document from some of the pro-life medical organisations, and there are numbers of them, and you could equally say, well, that's biased coming from a different point of view. So that statement was rejected by the case investigator because we know it's not true, and particularly say that there's no scientific evidence to support what we're doing. There's no safety record to support what we're doing is false. And the case investigators and the expert witnesses accepted that.
Thank you. It continues by quoting from two sources, which you might want to comment on. Dr. Edward Morris, president for the Royal College of Obstetricians and Gynecologists, said, quote, "We've become increasingly concerned about reports that healthcare professionals in the UK are prescribing progesterone to women and advising that this will successfully reverse an abortion," unquote. The GMC states that when prescribing a drug for a purpose that it isn't licensed for, then a doctor must be satisfied that there's sufficient evidence or experience of using the medicine to demonstrate its safety and efficacy. We don't believe this to be the case when using progesterone in that way. You've already answered the medical issue there. Is there anything you want to say about that statement from Dr. Edward Morris?
No, again, it's his opinion. It would not be an opinion shared by every obstetrician within the RCOG, as turned out to be the case from two of the fellows of the RCOG who accepted that what we were doing, while there wasn't a strong evidence base for it, that there was sufficient evidence that it, and sufficient safety record that it, that they found no problem with us continuing to provide that service using progesterone in that context.
Thank you. And Dr. Tracy Masters, abortion care lead at the Faculty of Sexual and Reproductive Health Care, said, quote, "No reputable medical body recommends progesterone treatment for this indication. We are concerned about this off-license provision of progesterone, especially when supplied in non-standard clinical settings. We often hear that those clinicians involved fail to give objective counselling on the very limited evidence behind this treatment," and she puts treatment in inverted commas. "We also hear that they fail to support them to an abortion pathway if the woman later returns to this choice. On the rare occasion when women change their minds after initiating an abortion, they need to be offered genuine, unbiased support and choice around," I never quite know what the word around means and why we can't just say about, "their options, whether it be continuing the pregnancy if still viable or opting to return to abortion." Is there anything you want to add that you haven't?
Yeah, two things. First, she uses the word often. We often hear, and then that was actually one of the, it's not so much relevant to this in this context, but the medical director of MSI did try to pressurize one of the women who had come to us. Now, as it turned out, she was one of the girls who didn't start the progesterone. I arranged a progesterone prescription for her, but she actually went back to MSI, told them what she had done, and they persuaded her not to take the progesterone, but to proceed with the abortion. And then they tried to persuade her to give evidence against me, because she subsequently she was one of the many girls who developed a significant infection as a result of an incomplete abortion with her, even though she'd taken the 2 abortion pills and hadn't taken progesterone. They tried to say that it was because I had offered her progesterone that I caused this infection. So they tried to persuade her, and we actually have a copy of the letter they wrote to her, to say that they said many other women have come to us reporting this, doctor. Now that was a lie, because we know that was not the case, and they weren't able to produce any material evidence at the investigation to show these many other women. So the groups like this tend to use words like many others or often, but without any evidence to support the allegation that they make. So that's the main comment I would make on that statement. But also you can see that all these statements are coming from people who have a vested interest in providing abortions. And they say that we don't then redirect them back to the, but we're not there to provide abortions. We're offering a service to women who want to save their babies. We don't tell them you must not go back and have your abortion. If about 35% of the women have decided for whatever reason that they're not going to go ahead with the treatment we offer, and we don't try to persuade them otherwise. It's their decision, and we don't try to force our beliefs upon them. And certainly there's no evidence to suggest that we do. So all of these statements are coming from the same group, but without any substance or any evidence to support the allegations that they're making.
The statement also quotes Bert Harley Lamb, BIRTE, not sure if that's male or female, Executive Director, midwife, I presume, at the Royal College of Midwives, said, that this is a worrying development. It's vital when women are making decisions about their care that they have evidence-based information on which to make these important decisions. It's also crucial that the advice and support they get from health professionals and others is unbiased and lays out the options they have without pressure or suggestion, so that women can make the choice that is right for them. Failing to do this is failing the women we are all here to care for. And then also quotes Dr. Jonathan Lord, co-chair of the British Society of Abortion Care Providers, who of course made a complaint to the GMC about you, who said, "We are concerned that there are anti-abortion groups recommending progesterone, and as a medical organization, we wish to make it clear that this approach isn't supported by clinical evidence. Individuals who prescribe these untested treatments act outside regulated care systems, and it's likely they won't offer impartial advice to women about all of their options. This is distressing and confusing for the women involved at a time they may be especially vulnerable. Healthcare professionals working in abortion care are experts in the provision of evidence-based information and non-directive counselling, and are best placed to provide the support, counselling and safeguarding for whatever choice is best for their needs. Whether that is continuing with a pregnancy or proceeding with an abortion." Now, you've already said that the tribunal and the experts at the tribunal rejected the accuracy or the lack of bias of these statements. So just in case you have anything else to add, please do so.
Yeah, there's probably not a whole lot to add on that. Yeah, I think it's self-explanatory. So it's coming. So they said there is no reputable evidence. That's because they haven't taken seriously the reputable evidence, the evidence that is there. When they say there's no clinical evidence, there is evidence, and that was highlighted by the expert witnesses that there is evidence, but people can choose to ignore evidence or to accept evidence. So these people are obviously deciding to ignore the evidence that doesn't fit in with their own ideology or their own rhetoric. But the evidence is there, and it's there for all to see.
There then follows a question and answer addendum. I won't quote extensively from that, except to ask you this. It states this in answer to a question. What was the question? The question was, well, it actually opens with this: Mifepristone prepares the uterus to make its response to the second medication more effective. The second medication, Mifepristone, will cause the womb to contract to bring on cramping and bleeding, resulting in the loss of pregnancy in almost all cases. Now, Robert raised a question about that, but this seems to suggest, does it not, or am I wrong, that ingesting a drug that induces cramping and bleeding in a woman is somehow normal and reasonable? What do you say about that?
Well, that's what happens. Having said that, it's the Mifepristone actually that causes most of the bleeding. Most of the women will bleed with Mifepristone, and then the Misoprostol causes contraction of the womb, which sometimes happens anyway, because unfortunately in the cases where the rescue treatment hasn't worked in our situation, that's what women experience. They experience bleeding, sometimes a little bit light initially, and then it becomes heavy, and then they get severe cramps, and then they miscarry when it hasn't worked. Misoprostol, the second drug, intensifies that. So even if the mother hasn't experienced severe cramps, if she takes misoprostol, she almost certainly will. So in most cases of chemical-induced abortions, the women will experience bleeding and severe cramps and will subsequently miscarry. Sometimes it's incomplete, so we don't know what the exact figures are. They say that it's less than 1%, but we know from women who attend emergency services, and there's a recent study from Ireland confirming this, that the incidence of complications after chemical abortion is much higher than has been up until now believed, or at least published. So misoprostol causes severe cramping. It causes uterine contraction, but that already has taken place in many cases, even before the misoprostol has been taken.
I suppose what I'm getting at is that if abortion is a medical procedure, it is unusual, if not to say unique, in that it is a medical procedure or treatment which is not designed to treat any known disease, on the assumption that pregnancy is not a disease, which I think most people would accept, it being quite normal and natural way to reproduce the human race. Given those circumstances, given that fact, a drug that is going to induce cramping and bleeding would on the face of it appear not to be normal or reasonable. Am I wrong about that?
Well, I think you're right. The abortion providers might disagree with you, that they would think that that's a normal and reasonable thing to do, but that's what it does. It empties the uterus, basically, or the aim is so. If a woman in pregnancy takes both abortion pills, there's a 98 to 99% chance that her child will die. It's probably around a 92 to 93% that the abortion will be complete. There'll be a 6, 7, maybe up to 8% chance that there'll be an incomplete abortion, and she might require further doses of Mifepristone, the second drug, or she might require an infusion of a synthetic drug called Syntocin to cause further cramping and further contraction of the uterus, or she might require a surgical intervention. So yes, so these drugs are potent drugs. They induce miscarriage, they cause bleeding, they cause severe cramps. Sometimes they don't operate as the providers would like them to operate, and some additional treatments can be necessary. Sometimes serious complications arise from their use because of an incomplete emptying of the uterus, leading to persistent bleeding, persistent pain, and in some cases severe infections, which can be life-threatening in a small number, in rare circumstances, but women have died from these infections induced by abortion.
In answer to a question, is it dangerous to take progesterone after the first abortion medication, Mifepristone?
No.
It answers thus and says, although progesterone is a commonly used medication, so that supports what you were saying, for other reasons, such as period control or as part of IVF, it does commonly cause side effects and is expensive. Those that prescribe it following Mifepristone use very high doses. Well, you've already told us that you don't use low doses. And without any evidence of benefit, it means the only effects are negative ones, such as bowel disturbance, bloating, and mood disorder. Any comment on that?
Bowel disturbance in the sense of nausea, not so much having a diarrhea or constipation or abdominal pain that we know of. Nausea, yes, that is a common side effect, and we prepare the girls and we offer them antiemetic, anti-sickness treatment if they wish to take some. Some do and some don't. We certainly don't use very high, extremely high doses. Well, one of the accusers in Manchester actually was a young man who approached me and screamed at me that I was hurting or damaging women, and that I said, in what way? He said, because you're using extremely high doses of progesterone. He said, doses that cause cancer. I said, okay, what evidence you have? And he didn't have any evidence for the cancer, but then he said, but you're using dangerous doses of progesterone. And he said, the Royal Colleges say that. And I said, okay, well, do you know what dose the Royal College of Obstetricians of progesterone or do you know what treatment the Royal College of Obstetricians recommends for a woman with a threatened miscarriage? He said, and he screamed, I don't know. I said, well, they use progesterone. He said, do you know what dose they recommend? He said, I don't know. And he screamed, I don't know. And I said, they use exactly the same dose what we use, except they use it for a much longer period at a much higher dose. And we use a high dose as recommended by the Royal College for 3 days, and then we reduce it to a lower dose for a minimum of 2 weeks and sometimes longer, depending on the gestational age at that stage. So they're the sort of issues that are brought up again and again, that we're using dangerous drugs, dangerous doses of dangerous drugs, but absolutely no evidence to support that. We're using the standard doses that have been used for decades, effectively and safely.
Well, you may have answered this. The next point that it says is, on its own, Mifepristone may prevent a pregnancy from continuing and cause a miscarriage. But studies have shown that even in higher doses than now used in abortion care, many pregnancies continue and are not affected after the first tablet. There is no evidence that Mifepristone causes birth defects.
Yeah.
Is that true? Is that correct?
That's true, yeah. The Mifepristone, and that was our main concern before we became involved, that, if the child survives, will there be serious birth defects? And there isn't any evidence that Mifepristone will cause birth defects. It'll either kill the child very early within the first week or so, or it'll have no long-term effect. But even the pro-abortionists would support that. I think they have to, otherwise they would be in danger of having to disqualify their own medication that they like to use.
Yeah. Finally, there was a statement by the American Pregnancy Association as there's the third reference in this, the university's statement, which rehearses much of what has already been covered. Unless you have a specific comment about that, I'm not sure we need to go into that in any more detail.
No, because they're all following the same theme, talking about dangers, lack of effect. One of the mentions is, or one of the allegations or statements made in the last statement was that Mifepristone itself sometimes, despite taking Mifepristone, sometimes the pregnancy will continue, and that's true. We tell women that there's about a 20% chance. Now, the studies that have been done on that only go to 15 days, so we don't know what the actual birth rate is after a woman has taken Mifepristone and doesn't take misoprostol and doesn't get progesterone treatment. But we know that to 15 days, there's roughly a 20% chance. Again, it depends. Different studies have shown figures ranging from 0% up to 25%. But I think it's reasonable to say that there's about a 20% chance that the baby might still survive if the mother doesn't take misoprostol, but if she doesn't receive progesterone. What we're offering is additional treatment to try and improve that survival rate without any risk to the mother or without any risk to the child, if the treatment works.
Thank you. Now, in a letter from Stephen Hall, you mentioned him earlier, he's a political advisor, a curious position, but I suppose necessary these days, to the President and Chief Executive of the Royal College of Obstetricians and Gynecologists, where he states this: women are being placed into the hands of two clinicians in the UK via religious groups. One clinician is the president of the Catholic Medical Association, and who is a cardiologist, and therefore this is completely outside of his speciality. The other is an obstetrician gynecologist who has done a number of webinars for groups like March for Life UK, Society for the Protection of Unborn Children, and Christian Concern. So what do you say about that?
Yeah, we do. Both myself and Dr. Riley have been advocates for life. That was the concern that hurt me the most, if you like, or offended me the most, to the fact that they were using that letter even more than the complaint by the director of MSI, which I expected in a way, and the tone of his complaint. But the one from the RCOG, specifically referring to our Christian status and our work with, our independent work with pro-life organizations, as if that was something that was a threat to women, or to the health of women, and then the fact that specific complaint, or those specific complaints, were endorsed by the GMC. That was what I found the most offensive, actually, in the whole case against us.
And have any of those organizations pedaled back on that or withdrawn their statements?
No, not to mind, not that I've been made aware of anyway.
Even given the fact that you've effectively been exonerated by the GMC's own tribunal.
At the GMC, nobody has apologized. Nobody has said, sorry, we were wrong, we made a mistake, carry on with you. So then, no, there has been no withdrawal of any of the allegations that have been made, or any apologies offered to either of us.
Did you say the GMC has apologized or hasn't?
No, the GMC haven't apologized. They just stated the fact that
no one has apologized.
Nobody has apologized. Not to me or to Dr. Riley, as far as I know.
Yeah. Yes, indeed. Thank you. In the evidence, there's also included the poster you mentioned entitled Manchester APR. Is there anything you wanted to add about that? I mean,
not really. I didn't know about the poster until Inga sent me a.
Let me, just before you answer, perhaps there's only a short portion, I'll just quote it. Dermot Kearney claims to offer an, quote, abortion reversal pill, unquote, despite medical bodies having stated this is, quote, unethical, unquote. They don't specify which medical bodies, quote, unproven, unquote, and dangerous, unquote. Kearney is now coming to our campus to spread this lie, which has seen women hospitalized for blood transfusions. This is not about a difference of opinions. This event is pushing a message that has and if unchallenged will continue to cause deep physical and psychological damage. The event is closed and is not even pretending to be a debate. Instead, it is a celebration of a man who nearly killed at least 2 women.
Right.
So that's what they said.
Yeah.
Your comment, please.
Well, there's no evidence to support that, for a start. I think it's coming from, I gave a presentation in Glasgow in 2020, December 20, or the end of November. I think it was St. Andrew's Day, actually, in Glasgow. Again, the pro-life students group invited me to Glasgow. So it was St. Andrew's Day in 2022. So after the case had been dropped against me, and we were back providing the service again. And a few days later in the Times, there was an article written by, so a journalist had attended the meeting. We knew she was there. So I was particularly careful to make sure that everything I said was factual, was based. But she used a phrase that had been used by a Scottish politician called Gillian Mackay. I think she's a Green Party MSP, I think, who, again, using the information that she received from groups like Open Democracy and the people opposed to what we were doing, she used the term unethical and dangerous. So the headline in the Times was that doctor admits using unethical and dangerous drugs. And then there was an article ignoring most of what I had said in the article. I pointed out that some women had some bleeding, and I described the Mitchell-Crinan study. It is true that a small number of women both those who've managed to get the progesterone and those who haven't had, particularly those who bleed beforehand, a small number of them have had heavy bleeding. Now, I don't know the exact numbers on that. I do know of one girl who, unfortunately, the treatment didn't work, and very early on, she did lose a lot of blood after taking Mifepristone, and she was hospitalized and did need a blood transfusion. And that may have happened with others that wasn't brought to my attention. I think it's unlikely, because I followed up all of the girls, except those who declined to respond to messages afterwards. So I followed up very vigorously to find out, and many of them had serious complications. I only know of one girl, and I did mention that story. I did mention that 2 women in the Mitchell-Crinan study, 2 women who had received placebo, not progesterone. So I suspect the journalist either misunderstood or misinterpreted or deliberately twisted what I was saying, and tried to say that I was responsible for hospitalizing women in this context. It is true that treatment doesn't always work, and we have to point that out, and I point that out to the women. I tell them that there is a risk of bleeding, but the bleeding is not caused by the progesterone, it's caused by Mifepristone. And that was accepted, because these were considered by the case investigators in the GMC, and they looked at all of the evidence, both for and against abortion pill reversal, and they concluded that it is widely accepted Mifepristone causes bleeding. Progesterone, there's no evidence anywhere to suggest that progesterone causes bleeding. And if anything, particularly if the treatment works, it might reduce the chance of bleeding. And that's what's suggested in that very small Mitchell-Crinan study, that the women who received the progesterone didn't have any serious bleeds and were less likely to have a serious bleed compared to those who didn't. But progesterone is not always effective, so women will have some bleeding. So that's what I would say to that allegation. Otherwise, so it's based on the false allegations that were made from a statement made by a Scottish politician that was taken up by the Times newspaper and then has been used by pro-abortionists and people opposed to abortion pill reversal ever since then.
Yeah, so the bleeding is caused by Mifepristone. Yeah,
that's why
Mifepristone is provided by the abortion provider, not you. And the bleeding is not, so far as anyone has been able to determine, caused by progesterone, and that is the only drug provided by you and your colleagues.
Yeah, absolutely.
So it was simply a false statement. Did you consider suing any of the makers of these false statements for defamation?
We wrote to because the Times newspaper, the article was particularly damaging and has been used against me ever since then. That was in early December 2022. We wrote to the editor of this, I think it was the Scottish Times, and he dismissed it. He said he stood by. We considered defamation, whatever, but I raised it with the Christian Legal Centre, and they didn't feel it was something that should be pursued, at least at that stage. So maybe we should have, but we decided not to take it any further.
Is there still ongoing damage to you caused by these false statements?
Yeah, well,
Manchester
was the main one recently, yeah, because they used that article for their statements that they made on that poster. Again, a lot of I'm online quite a lot, and not only talking about this issue, but about other issues too. But that is sometimes brought up, especially when abortion pill reversal. Someone will stick up or post that headline from the Times, and then I asked them if they would like to discuss it. This is something that anyone who's opposed to abortion pill reversal, I always ask them whether they're from a representative body or whether they're an individual. If you would like to hold a live, public, open debate, respectful debate, I would be very happy to do so. And not only myself, but some others who provide the service to women, both in this country and in the United States, have offered to hold public debates so that the public can see and judge for themselves. But the offer is always declined, because they know that we have the truth, and we have the scientific basis and the evidence to support what we're doing. But our opponents do not want to engage in a live public debate with us. They'll make statements and then hide behind the statements.
And then, of course, there is a letter of complaint, or one of the letters of complaint, which we have in the evidence to the GMP, about you from Dr. Jonathan Lord, the medical director and responsible officer of Murray Stopes International, and a consultant gynecologist. Murray Stopes, of course, being a very well-known abortion provider. I won't take you through the letter. I'm sure you've seen it already, and it'll be in the evidence for this inquiry. But is there anything you particularly wanted to draw our attention to in that letter?
Again, the allegations, as turned out to be the case, were false. The only thing he got right, I think he specifically said that I did not follow the abortion guide, the NICE abortion guidelines, which is true, because I wasn't providing abortion. So that was true. But he made other accusations, such as using this dangerous treatment, not licensed or off license, imposing my beliefs on vulnerable women, Catholic beliefs, pro-life beliefs. So none of them had any foundation. And the statements that came from the women themselves all highlighted that these allegations were false. Because I had no part in the interviews with the women concerned. I just asked the women, would it be okay if a legal person contacted them, and if they asked them some questions, and we just asked 10 of the women, and they were very happy to do so. And all of them, some of the questions they were asked were things like, do you know what religion Dr. Kearney is? Did Dr. Kearney ever mention any? No, we don't know. That wasn't part of the discussion. So I certainly did not try to impose any religious beliefs, pro-life beliefs. I had an open discussion, telling them the facts of what we can do, what the success rates were, what the failure rates were, what the side effects to expect could be. Reassured them that there wasn't any evidence of any increased risk to the child if the child did survive, but the chances were, I usually said 50 to 55%, whereas if they didn't take progesterone, there was about a 20% chance that the child. So I gave them the option. So we were accused of not providing options by a number of groups, including Jonathan Lord. We were the ones who gave the option. They were the ones who closed down the option that we were providing.
Yes, I mean, he makes the usual allegations, prescribing an unlicensed prescription-only medication, no evidence base, outside the scope of any valid clinical guidelines. You've answered all of that. Those allegations are not accurate, you tell us, and indeed the tribunal seems to have agreed, as did your expert and the GMC's expert. But he then says this: there was no attempt to inform or discuss her care, this particular individual who's seeking an early medical abortion, with our clinical teams, even though we had primary responsibility for her care. Do you want to comment on that?
Yeah, because this is an emergency situation. We know that time is of the essence here, which sometimes is too late. So we know that the sooner we give the rescue treatment, the progesterone treatment, the better. So we don't have time to discuss with other care providers, and also the care provision. Like the woman comes to us with a specific request for a specific type of treatment, which is diametrically different or opposed to the treatment that they had offered. She now wants to, she has withdrawn her consent, basically. That's the way we viewed it, from proceeding with the abortion, at least at that stage. And she wants to pursue this other avenue of treatment. So to spend time trying to contact an abortion provider to discuss the issues with them would increase the likelihood that the treatment will be ineffective, that the child will not survive. So in emergency situations like that, you don't have time to go. Now, in many cases, I did ask the girls, I ended up stopped doing it because they usually said, no, please don't. I asked them, do you want me to discuss this with your GP? Because I think it is important that GP should be involved in any of the care, but most of the women concerned do not want this incident to be on their medical records. Some of them did, and in a small number of cases, I corresponded with GPs, and in 1 or 2 cases, the GPs were very grateful and actually were prepared to continue with the progesterone treatment that I had started. In a small number of cases, they because we always had to try and get a scan. I don't have access to scans, so I would always direct the girl to try and get a scan as soon as possible. Because if the child is already dead or there's no viable pregnancy, then there's no point continuing the treatment. So I didn't want her taking treatment that was going to be ineffective, that was going to cause her side effects. So we tried to organize scans, and they would always ask me, do I have to tell them what I've done? I said, that's entirely up to you. I said, you're within your rights. It's always better if medical professionals looking after you are aware of all of the circumstances, but you cannot be forced to give information that you want to maintain confidential. And I certainly won't inform people unless you ask me to. So I always gave those extra statements to the women concerned if they raised the issue that they were concerned about other people finding out about the situation that they were in. So it was an emergency situation. We respected the confidentiality of the mother. We encouraged her to discuss it with other medical professionals, but certainly didn't try to force her to do so.
Yeah. Part of the summary of his letter, he says, and you've already responded and answered this, that you prescribed a prescription-only medication in which a randomized controlled trial to test its efficacy had to be stopped on safety grounds, and for which there is no evidence of benefit. You've already answered that. That was their own, or at least the abortion provider's own test, and they stopped it because their method, not your method of testing, was unethical because it could result in problems for the women concerned, where they weren't given the progesterone but were given a placebo. So I think you've answered that pretty fully, unless there's anything you wanted to add.
No, that describes exactly. So that was his interpretation of that study. We and many others would hold a different interpretation as to what actually happened.
Indeed. But what
can I just come in here, Jamie, just very quickly? I'm aware that Nina and Peter both need to leave us.
Yeah, I've nearly finished. I'm nearly finished, Linda.
Well, I was going to suggest that we had a short break as they leave.
Well, I'm very nearly finished. So if I could just get to the end and a break, that would be the appropriate moment for a break.
Okay.
What he says in his letter is the personal beliefs of Dr. Kearney appear to have been imposed on the patient without any attempt to present an impartial, evidence-based approach to her care. That, of course, you've answered more than fully already. But then goes on to say, money was transferred to the patient's bank account. The patient expressed distress that she felt, quote, scared of, unquote, and, quote, in debt, unquote, to Dr. Kearney following his transfer of money to her. What would you say about that?
Yeah, that was one of the accusations about transfer of money. And that was, in fact, that was the only issue that the expert witness from the GMC just wanted some clarification on, because in some cases, the girls were not able to afford the progesterone treatment. Progesterone is not expensive. It's roughly, I would give 2 weeks treatment at a time, because I didn't want them spending money on something that may not work. So I'd get them in 2 weeks, and that cost roughly £20. Most of the women said, that's fine, that's no problem. I want to save my child, I'm happy to do that. But some didn't. Some said, I don't get paid till next week. I'm really sorry, but I can't afford it. So I would say to them, if that's the only reason that you don't want, if expense is the only reason that you don't want to go ahead with the treatment, I will pay for you. Now, initially, we tried to do so by paying the pharmacist, but pharmacists, for some reason, I don't know why, but they wouldn't accept an external person sort of transferring money on a phone call or online. So we had to, in some cases, transfer whatever the pharmacy costs are going to be to the funds of the girl, so she could actually pay for the drugs. So the way we put it was that they get the abortion drugs for free. It's a phone call consultation. The drugs are sent out and they don't have to pay anything. And we felt it was unfair that if they have to pay they get to kill their child for free, and then they have to pay money to try and save the child, and when they can't afford to do so. So
in effect, it is the abortion providers who are subsidizing the patient's procedure by providing free abortion drugs.
Even free abortions, yeah. So we felt to even the playing field, we felt that. And now initially, the first time I did it, I thought, well, I'll probably claim the money back off one of the pro-life organisations. But then I thought, it's £20. I'm not going to take money from a charity that needs it desperately for other reasons. So it became a small account that we set up, that myself and my wife, that if a woman was in desperate need, wanted to save her baby, didn't have the funds to do so, we were happy to give them £20 or 25, whatever, because usually about £20. London may be slightly more expensive, but whatever the pharmacy cost was, we gave them that. We offered to pay them. Most of the girls, so about 95% of the time, they said, that's fine. Thank you for the offer, but I don't need it.
What about the claim that the treatment was outside your area of professional competence?
Again, that was addressed. First of all, it's because it's been accused, what's a cardiologist doing that? Well, I'm a medical practitioner, and the expert witness actually handled this, I thought, very well. He said, well, let's look at the basis for the Abortion Act. Who was allowed to provide or to recommend or to sign the papers for an abortion to take place. And you don't have to be an obstetrician, you don't have to be a gynecologist, you could be an ophthalmologist, a psychiatrist, as long as you're a registered medical practitioner who in good faith believes that grounds A, B, C, D, or E are necessary to procure an abortion. He said the same standard should apply to this issue, that you do not necessarily have to be an obstetrician. The way I put on it is that 98%, my response to that allegation was 98% of all abortions in this country are performed on the basis that continuing the pregnancy will harm the mental health as opposed to the physical health of the mother. And we know that from the forms that have to be filled in and the boxes that have to be checked. 98% year after year are done on the basis that continuing pregnancy will harm the mental health. And none of these women, or at least very,
but that's not strictly relevant because you're not a psychiatrist, are you?
Yeah, so psychiatrists don't.
And you are a GP, aren't you?
I'm a cardiologist, but I'm also a general medical physician.
You're also a general medical physician.
Yeah, so progesterone is a steroid hormone. I routinely prescribe prednisolone, hydrocortisone, dexamethasone, fludrocortisone. Not so much progesterone, except in this situation, because it's a very specific situation. But you could argue that abortion pill reversal is an endocrine issue. It's not an obstetric issue. It's an endocrine. It's a general medical issue where a woman needs a medication, generally available medication, that's not restricted to certain groups of people to prescribe. GPs can prescribe progesterone to a woman with a threatened miscarriage. And in a way, I'm a specialist in that sense, in that I deal with all comers who come with a general medical problem. If I happen to be on call covering the emergency department or the emergency admissions, and a woman comes in with some non-cardiac general medical problem, I'll be the one taking responsibility for dealing with it. So, and this was a similar type of situation, and that's the expert witnesses both agreed that was not a concern that needed to be looked into in great detail.
Yes, thank you. I've just two more final questions, then we're done. We heard that the GMC, I think, was it the Interim Orders Tribunal that dismissed the complaint and the conditions?
The MPTS.
That was MPTS, was it?
The MPTS, they're the one, because they imposed the conditions attached, so they were the only ones who could lift it. The GMC recommended, the MPTS responded by that this is our decision. So they had to be the one. So then the GMC recommended that the case should be dropped. So the MPTS had to then drop the case, like finalize dropping the case.
And did they provide a written judgment or anything in writing that we can have?
Yeah, they were not the MPTS. I think the MPTS just said that on the recommendation of the GMC that they have removed the conditions that had been imposed. But there was a written judgment from the case examiners. I don't know if I sent a copy to Edmund, but I can.
Can you send a copy to Edmund?
Yeah, that'd be fine.
Thank you. And then,
Jamie, can I just come in here briefly? Because I'm very much aware that Peter and Nina both need
I've got
to.
one final question. That's it.
Okay, but so you said that 2 minutes ago with two questions.
No, I said I had two questions. I've done one and I've got one to come.
I thought, okay. Well, we might have to let Peter and Nina just go, I think, with our thanks for having been a part of the panel now. So
Okay.
Thank you. God bless.
Thank you.
Do put your question,
you.
Jamie.
Thank you, Dermot.
Thanks, Nina. Thank you, Peter.
And that question is this: you've obviously suffered some discrimination, but have you suffered any discrimination in your professional capacity from any other sources or agencies?
I don't think so.
Exoneration?
I don't think so. In my own hospital, we're a little bit concerned, obviously, and I had to go and meet my medical director. Every hospital has a responsible officer and medical director who looks after the medical staff within. So I had to go and meet my medical director on a regular basis while the case was ongoing. And he's retired now, but he was an obstetrician. But on the very first meeting, he said, "I have to admit, I know absolutely nothing about this, about abortion pill reversal. I don't have any strong feeling one way or the other on it." I found out later that Jonathan Lord from MSI had actually contacted him in as early as January of that year, unknown to me. But he revealed that a number of telephone conversations had taken place. John Lord was looking for any information to see was there any other charges brought against me in my professional capacity working in the hospital that I worked in, and he had to say no, there wasn't. That basically an unblemished record, which is why when the GMC asked for an 18-month complete suspension, the MPTS took that into account, that there were no other complaints about Dr. Kearney or Dr. Riley from other sources outside of this. So to impose a complete suspension and prevent us from carrying out our normal medical duties would have been disproportionate. So I received quite good support. I think there probably is a legal obligation on the medical director to regularly review the staff who are being investigated, because there have been a number of suicides of doctors who are being investigated by the GMC. And I think there is a concern for if nothing else, for mental health and morale reasons. So I would go in regularly every 4 or 6 weeks for meetings, and his very first question would be, "How are you?" And I say, "Oh, I'm fine." And then he always looked puzzled. And then he said, are you sure you're okay? Because I think he expected that I would have been very distressed or upset by what was going on. But I actually didn't let it interfere too much with my personal or professional life. I just carried on as I normally would. I was the day of the tribunal, and when the conditions were imposed upon me, I was very annoyed. I was angry. I was disappointed because I realized that women were still needing the service, and now they wouldn't be able to avail of it. But that soon passed off, and I just carried on as normal until, and then working with Christian Legal Centre and Christian Concern until the issue was finally resolved. So I'm not aware of any other infringements upon my professional life or working. They did say that their main concern was that the name of the hospital I work in would not be revealed. And I said, that's fine. Now, some did reveal it, usually on the opposing side, because it's easy to find out where individual doctors are working. But I certainly, and anyone I've spoken to, I said, I'm happy to introduce, but just please do not reveal the name of the hospital or the exact location of where I work. And that I respect that, because they were afraid of protests either for me or against me. They didn't want to bring the hospital into disrepute, and I totally respect that. And I've been very careful as far as I can. So anything that's published about me with the name of the hospital is certainly not something that I have given the permission for. So, but they were quite supportive over the years. But they did ask me not to talk to other members of staff about the issue as well, which I've respected. A small number of people did come to me privately because they had read about it in the media or seen it or seen a picture, and they read or they Googled me and got more information. So a small number of people and a small number of patients have actually asked me about it in a very positive, supportive manner. Nobody has criticized me or tried to get me into trouble over my activities in that regard.
Good. Thank you very much indeed. I'm most grateful to you, Doctor, for giving evidence.
Thank you.
Thank you, Jamie. Robert, I'm aware that you have a couple of questions. I'm also aware that time is marching on very rapidly. So if we can keep them brief, please.
Thank you, Linda. Dr. Kearney, can you just clarify what the meaning of a general medical physician is compared to that of a general practitioner?
Yeah, so it's working within the context of a hospital. So in my training, I have what we call dual accreditation. So I've got specific training in cardiology and all of the various items in the curriculum that that have to be addressed for a cardiologist to be considered, like to be recognized by the GMC as a cardiologist. But there are also some aspects to your non-specialist training that you have the choice actually nowadays. And when I was trained, I trained in Ireland mostly, but and a little bit in the Netherlands. But in those days, we had to do, as well as because cardiologists often have to deal with patients with non-cardiac problems who happen to have more than one condition. So it is important that doctors should have at least a wider knowledge and experience of other conditions outside of their own main specialty. So I have obtained dual accreditation for general medical training, which I had to do over a number of years, do general medical on call, attend general medical clinics, work with non-cardiac consultants, obtaining their experience, and then for them signing off whatever levels of experience I had achieved. So it's a recognition that I have skills, knowledge, competency in cardiology, but also in other areas of medicine. So that would usually mean things like respiratory medicine, gastroenterology, endocrinology, nephrology, neurology. Obviously not surgery, so I don't perform operations on people. I don't cut them up, except maybe putting a minor procedure like a pacemaker or an angiogram. But so it's a recognition that you have this ability to, and then you maintain those skills by participating in the general medical on call for your hospital. So you maintain those skills, month by month and year by year.
That's very helpful. I just have a few questions about the protests outside Manchester University when you were scheduled to speak. Was the event advertised as, you used these words earlier, offering women a second chance? Was that effectively the title of the event?
Because Inga asked me what title, and I said offering women a second chance. Abortion pill reversal in the UK, but offering women a second chance was the main sort of topic of the main headline of the title of the presentation.
And I think you said there were at least 100 protesters outside, approximately?
I estimate there was at least 50, so probably 70 to, I think probably less than 100, so 70, 80, 90, but it was still, some were coming and going, and some I didn't know some of them were standing a little bit of a distance. I didn't know were they part of our group, were they part of the protest, and some possibly for security people, but there was probably at least 70, somewhere, but less than 100.
Were you at any stage physically assaulted? And by physical assault, I'm defining that in terms of unwanted touch, where you, the alleged victim, perceive threats to your physical safety.
No, I have to admit, I don't think so. There may have been, as we were coming through initially, so there was a crowd gathered outside the main doorway, but there was also they were along a pathway, so we had to make our way through the path. So there was maybe a little bit of sort of pushing, but it was more shouting.
And were there?
I certainly didn't feel physically in danger at any myself. I didn't. I was more concerned because most of the personnel in our group were female, so I was more concerned with their safety. That because obviously they would be frightened, especially if they hadn't experienced something like this before.
Were there any verbal threats made?
Oh yeah, well, verbal threats, but just to F off and to that I wasn't, made it clear that I wasn't welcome here, and
Right.
so.
And
But
you said
not threatened, like I wasn't threatened with rape or being killed or damaged in some way.
You said that there were 2 police officers and 2 who were plain clothes. You also mentioned reinforcements were expected. Did those reinforcements finally appear?
No, I don't think so. I certainly didn't know. So that's what we were now. I was told, because I would ask every now and then any news of what's happening, and one of the pro-life organizers said, "Oh, we've spoken to the police officer and they say that they're waiting for reinforcements." Now I don't know how genuine that was. Maybe it was a busy night in Manchester and they weren't able to send. But certainly no officers in uniform arrived apart from the 2 that were there. And I didn't know about the 2 plainclothes until one of the pro-life students was making his way along a pathway, and 2 protesters stood in front of him to block his, and then these 2 officers, who I was told were plainclothes, intervened to remove, because he was allowed to walk along the pathway. It's just when what was ironic was that at the end, because I mentioned that 3 of the students were already in the building and they were trapped. They couldn't get out. We couldn't get in. So when eventually we were leaving, the police and the security people, they did manage to make an open passageway for the 3 people inside to come out. And my question was, well, if they could do that, get the crowd, the mob, to stand back to let the 3 people out, why could they not have done the same to allow us to go in? And just that question was never addressed. But it might be one of the issues that ADF and the Council for the Free Speech Union might want to address.
You
said that they had the physical capability and probably the legal capability to allow us to enter the building, but they didn't seem willing to do so. But they were happy to get our 3 people to come out, who then attended the meeting with us and came with us.
You said that a number of the protesters had balaclavas.
Well, their faces were covered, and it was some had just face coverings. But 1 or 2 did have, what looked like balaclavas. But
and is it possible to say, maybe this is just not possible to say, but were most of these protesters women, or was it an equal mix between men and women?
Probably slightly more. There certainly were men there, because the person who was most aggressive towards me and was shouting about me giving this dangerous treatment, he was a man, and he had a megaphone, so he was one of the organisers, presumably, of the protest. But the majority would have been women, so 70-30, 70%.
And they were chanting slogans of some sort?
Oh yeah, plenty of slogans.
What kind of slogans, just for the
Dermot
record?
Kearney, the new one that I'd never heard before was Dermot Kearney butchers women. Dermot Kearney butchers women. That was the new one. They had the usual ones that F the church, F the state, women should decide our fate, keep your rosaries off our ovaries. And men were saying that as well as women do.
Right. Okay.
They're the main ones, but the new one that I'd never heard was about the butchering women. That was a new one for me.
Quite ironic, coming from activists who have pro-abortion views. Anyway, thank you so much for answering those questions. I appreciate that. Back to Linda.
Thank you, Robert. Thank you, panelists, commissioners. Dr. Kearney, thank you so much for coming and giving your testimony today. I just have one sort of, I'm not sure if it's comment or question, just to round us up, but it seems to me from all that you've said that there were no complaints from any other neutral, let me put in those terms, medical groups, medical bodies, and that all the complaints seem to have been very much coming from people of a particular perspective. And it seems that there was very much a sort of ideological imperative behind this attack on yourself that was very much promoting abortion. They call themselves choice, but it seemed to be very much promoting abortion. But there was no even criticism from other groups. Is that fair?
Oh, that's very true. And most importantly, and I highlighted this, there were no complaints from any of the women. All of the comments from the women were supportive. So I think that speaks volumes, because if there had been complaints from the women, then I would have certainly had to think twice about, should we continue to, if women are complaining because of this, of the service that we're offering, then maybe we do need to re-examine or reconsider providing the service if it is actually harming women. But then none of the complaints have come from women. None have come from neutral bodies, most of whom don't know anything about the issue. And even my medical director, friend, obstetrician, admitted that he knew nothing about it, even though he'd been practicing obstetrics for more than 30 years. He knew nothing about the issue. And one or two others, senior people, have come to me and said they know nothing about it either. But there were no complaints outside of the usual suspects that we've mentioned.
Which is interesting. That really does seem to underpin.
I think it's because people often ask me, why are they opposed? Because they say this that they're pro-choice, and yet this is a choice you're offering, and they oppose it. Well, why? And all I can say is that I think they perceive us as a threat, because and it goes back to the initial Daniel Grossman, because the original opposition was purely on the basis that women don't change their mind. But that was the initial argument. That they've gone away from that by trying to promote what they consider to be the dangerous aspects of it, because they realise that women do change their mind. But if you accept that women change their mind, the next logical question is, well, okay, well, why do women change their mind? If abortion is such a good thing and women are so sure of their decision, why are they changing their mind? And I think the answer, because I know certainly in this country it's the case, because they're not getting proper counselling. And we know from the women who come to us, they're and it's the same as in Ireland from friends who are working over there, that if a woman inquires about abortion, she's pushed in one direction, she's not given, they're very, maybe in some cases, but generally they're not given the other option, they're just pushed along. That's why we've got over probably 270,000 abortions per year in this country. So women are certainly not getting the psychological evaluation that maybe many of them should have. They're certainly not being offered the type of support, psychological, emotional, financial, practical support that is available to them if they were informed about it. And it comes from a lot of the pro-life organizations that are out there offering women this support. So I think we're looked on as a threat that to how dare you suggest that women change their mind, because if that's accepted, then serious questions then have to be asked as to why. And that can raise up a whole Pandora's box.
I think that pushes us towards the possibly unposable question of why certain sections of society want to push abortion, the killing of the unborn, which is what this is, quite apart from women being given counselling and help and support to save their babies. Just why is there one sector that is so determined to push abortion? And I'm not expecting you to answer that, because I don't think it is easy to give an answer to that. But thank you. I think your testimony is going to be enormously important in adding to our report. So thank you very, very much. We will obviously be putting up a preliminary report very shortly on the website of the hearing today. If there are any further questions that do come up, we will get back to you over the next few days if we may. But thank you everybody for your time this morning.